So we're gonna do
Okay, sounds good. I'll see you out there in just a couple seconds.
12 leads.
All right.
We're talking about 12 leads. We're gonna go over all things 12 leads. A lot of this will be new stuff for you guys that we haven't yet hit. Okay, so when you pay attention, stay with me.
And no, right into it.
Don't what?
Don't work on our packet while you're talking.
No, I mean, I just would prefer that so that we don't lose you. It's more about you than it is me. I'm here for you. Andrew, if this thing don't work,
I'm
I'm
here
gonna.
for you, privates. You asked my attention, now you have it.
Hold on, we get the camera.
I think you gotta look at name on.
It's flashing like it has me, but it hasn't got me yet. I think you got me now. There you go. All right, we're on. All right, so we're doing 12 leads. We have not talked about 12 leads yet. So we need to focus on this. What we talk about, what do we give with 3 lead? We diagnose anything with 3 lead?
Not really.
Base rhythm, that's it. We understand base rhythm off of 3 leads. When we get into 12 leads, we're identifying injuries, we're identifying those sprinkles on top that we haven't got to. So we haven't even talked about things like bundle branch blocks, and talked about some of those specifics. We're going to get into those now. Okay, so we use 12 leads to identify muscle injury and cardiac abnormalities, big words. Okay. When do we do 12 leads? We've already talked about that. We do 12 leads all the time. We're doing a 3 lead. Any patient sick, any single episodes, any breathing problems, any abdominal pain, chest pain, jaw pain, we're going to do 12 leads. We already said about lead placement quite a bit. How to get good placement in the hospitals, going to be wrists and ankles. In the field, you might come up a little bit, but we have to stay off the core. We cannot be up here going through the shirt. You're going to get false stimmy activations. You're going to get poor pictures. It's not what we want. So don't do that. Do you have any announcements before you leave for them?
You have the packets. Those are due next week, no matter what. That's mostly for the other guys. We will be doing the med term quiz and the cardiology med quiz next week. Just since the way it's probably going to end up working tomorrow. I didn't want to have.
Say that again?
They were supposed to have a med term test quiz.
Okay, I don't care.
That's you shut up.
All right. Cool. Good.
That's it.
Thank you.
Yep.
All right. So when we do this, we use the same interpretation we do for our standard lead. We look at we have P waves. Is our PRI equal or normal? Is our R regular or irregular? Is our QRS narrow or wide? And we start to get into it. I'm going to skip axis deviation for now. We're going to come back to that probably next week. Yes, next week. Axis deviation just confuses people a lot, and it matters. It does have a purpose, but it doesn't have a huge purpose in what we do. Right now, we're beginners, so we're gonna do some other things first, and then we're gonna come back to this. The first thing we're gonna understand is bundle branch blocks. And of course, there's a lot of words up here, and we know we don't like words, so just ignore the words for a second. Okay? If you're up there looking at all those words, don't freak out. When we identify on a 12 lead what a bundle branch block is, we look at V1. So we go to V1, and we look at the QRS width in V1. V1 is where we measure our width on basically all 12 leads QRS width. So if we have a 12 lead, when we're measuring width, we're going to jump over to V1. We've already identified our base rhythm. So let's look at this 12 lead real quick and identify that base rhythm. Do we have P waves? Is our PRI equal and normal when we have one? Yes. Is our R regular?
Yeah.
Yeah. QRS, is there narrow? Yes. So we're in some sort of sinus rhythm, yes? What sinus rhythm are we in? Do you guys need to rate for me? Because you can't see it. 300, 150, 175. What sinus rhythm are we in? We're in a normal sinus rhythm. That's what we're seeing on lead 2. Guys, I need you to know some 12 leads print off like this, where they have and I love this. This is what I prefer. You have your snapshot. 1, 2, and 3 is a 3-second snapshot. ABR, ABL, and ADF is a 3-second snapshot in line. So first 3 seconds, start of the next 3 seconds, start of the next, going across time. We're getting 3-second snapshots across time. But we have lead 2 printed down here at the bottom as an ongoing picture. So freaking handy if your monitor does this.
So your lead two is a whole full second.
Down here, yeah. Great. Why is that so important? Because you may see something funky in V2. See how this printed funny here? In V2, there's like a couple squiggly lines. I can't see what that is. But I'm going to look across the board vertically and say, what does that look like in other rhythms? Is that a PVC, a PJC, a PAC? And I think it's just a bad squiggle. We just got some interference. The printer jammed a little bit. I don't know. It doesn't look super clean. But we use that whole picture to say, it's not such a big deal. So now, when we're talking about V1, we're looking at the QRS width. Here's a really cool factor. When you do a 12 lead, your computer 12 lead prints stuff out. It prints out some analytics, some details. And one of the things it prints out is, typically it's called QRSD. You guys ever see that QRSD? QRS duration? That is the width of the QRS in V1. That is the width of the QRS in V1. And of all things your monitor is good at, because it's bad at a lot of things, right? Very narrow criteria, or very wide criteria to call semis. Docking the box is wrong on semi activations a lot, right? Yeah? But it's good at this. It's good at measuring, it's fairly good at measuring how wide is V1 from the beginning of the QRS to the end where the J point is. How wide is that? If we look at this lead here, we're gonna, oh, it's real small. Holy cow. Even I'm struggling up here. It's great. We're going to say it's greater than three small boxes. So 0.12 or greater, really greater than 0.12, greater than 3 small boxes. We're in a bundle branch. Okay? Greater than 3 small boxes, we call that a bundle branch. If, remember, we already had something we were measuring with, if we have P waves, right? So our underlying rhythm is what, first of all? Everybody think deep breath. Our underlying rhythm is normal sinus rhythm. It's not a ventricular rhythm. We don't say it's a bundle branch when it's idioventricular, because there's no P waves. The underlying rhythm does not match. Does that make sense? It's not already a wide rhythm. So what we have is we have a normal rhythm, but now we're too wide, and we have this little sprinkle on top called the bundle branch. And there's a right and a left bundle branch. We're going to go over that here in a second. So, we always talk about the same way. They have these big words. Terminal, R wave. That stuff confuses medic students. Use your blinker. If you flip your blinker up, nope, you're going right. So if that QRS is more up than it is down, if it goes up more than it does down, it's a right bundle branch. Do you see that? That's a right bundle branch we're looking at there. If it was more down than it was up, we flip our blinker to the left, going down, going to the left. That's a left bundle branch. So right is up, left is down. It's really quite that simple.
And it's based off the isometric one.
Yep, in V1. In V1. We're looking at V1 for bundle branches. Okay, so we get our width in V1, our QRS duration. That computer model will print that out for you, or you can count small boxes. I would always double check your computer model just to make sure you're set. Let's do this one. I can count that wide from here, okay? So go back to, oh, the underlying rhythm's junky. Let's look at that underlying rhythm. Looks pretty rough, okay? We're looking at all of our leads here to see, does anybody see P waves throughout any of our leads here? No, it's pretty rough, isn't it? Pretty rough. I'd like to find some just to make my example easier. Maybe there. They're pretty rough. See those? Need me to blow it up more?
Looks like there might be one in 4.
They need to be identifiable. And I'm struggling to say that this is a great example, but if we look at lead 1 here, I see a bump there and a bump there and a bump there, kind of the same place. We got wide, nasty beats here, so it's hard to see exactly what we're dealing with. I don't see really a good example in 2 or 3. You said what, 4?
Looks like 4 maybe.
Uh-huh. Okay, so we're struggling with that. We're struggling with what our underlying rhythm is. We could say if that's just wide with no P waves, what are we going to say it is? We're going to say it's a ventricular rhythm. What kind? How wide is that? What rate is that?
Probably accelerated.
300.
175.
So the accelerated idioventricular would be the base rhythm if there's no P waves. Let's say we can see clear P waves there. Clear P waves. And it's not idioventricular. If there's P waves, it's a sinus rhythm, even though it's wide. And then we're in what we would call left bundle branch. See how it goes down more than it goes up? We have left bundle branch. And that's what they're using for this example is a left bundle branch. It's just not super clear. That looks a lot like an idioventricular rhythm. Here, actually, here's a, you can see these in D1. See those P waves? They're pretty clear there in D1, aren't they? Now that I look at that. I kind of missed that. You got P waves there. So you have P waves. You have this wide, nasty beat that shouldn't be wide and nasty. You're in a bundle branch block. Okay. Does that make sense? Now you're looking at if it's right, how do we know it's right? It goes up more than it goes down. How do we know it's left? It goes down more than it goes up. Okay, the QRS. Do we need to freak out about bundle branch blocks? Well, no, not necessarily. However, if your patient's having signs and symptoms of a heart attack, as a bundle branch block, they don't know anything about it, we should probably be concerned because there's a blockage of the electrical system. Where is it at? It's in the ventricles, down by the bundle branches. Okay. What? Of the ventricles. Yep. And so now we have this issue, and we could be having a heart attack, but we're probably not. Now, somebody's going to freak out when they hear me say that. There's a criteria we're going to go over next week on how to really narrow down these things and get honed in better on what is a bundle branch, what is a heart attack. I don't have you guys memorize that. We use it as a reference.
So what are, I guess I'm confused what I'm looking at and want to determine.
Say that again. You're confused on what?
Like, so looking at B1,
Yeah.
I guess I'm just confused on what I'm actually looking at to determine the bundle range.
Okay. So you're looking at the width, the beginning of the QRS to the end. Okay. Even if we just said, hey, that's the end, and that's the T wave, that's more than 5 boxes wide, right?
Yeah.
So you're more than 5 boxes wide, you have a P wave here, P wave there, P wave there. So does that make sense? You have P waves, you have a QRS that are nasty and wide. It's a sinus rhythm. The only reason we know it's sinus rhythm, RRs are regular, PRIs are equal. We have P waves, so we have to be over there, even though it's wide and it's not supposed to be wide.
Okay.
So that width throws us off of our normal chart.
Okay. And then how do you determine left or right?
Oh, left or right. Does this QRS go down more or up more?
Okay.
If it goes down like this one does, you flip your blinker down to go left. This is down, we're going left bundle branch. If it went up a whole bunch, we'd flip our blinker up, and that gets us up for right.
And the only place that you're gonna be able to
D1. D1 is our place for bundle branch. This is sprinkles, guys. We got our 25 or so base rhythms on that other sheet that we've hit the last few weeks. This is the extra stuff on top. Have to have 12 lead to get to this. Gotta be able to look at V1. We need to know that QRS duration or measure that QRS duration.
So would you call this in as normal sinus rhythm?
That is exactly what I'd say. Patient's in normal sinus rhythm, rate of 75, he's got a left bundle branch block. If I'm going to a cardiac center, now I'm really looking at my patient. Mr. Smith is looking sick. Right? Mr. Smith's looking sick. He's looking like he's having a heart attack. We take those patients to least 7 normally, so again, they want least 7, be advised, room bound, 65-year-old male patient. Patient, pale, cool diaphragm, chest pain. He is in a left bundle branch block. We don't know if that's new or old. Be to your facility 15 minutes, here's vital signs. Some places are going to activate that because you see how this could look like a STEMI? Let's look at this. V1, well, we haven't talked enough about STEMIs. Let me go over STEMIs, we'll come back to this, remind me, okay? Let me go over STEMIs first. I think we'll do that first, okay? We're going to skip these little blocks for a second. These are electrical blockages we're going to come back to. Let's get to STEMIs real quick, and then we're going to come back. I do this a lot where I jump around in this slide set because I don't like it the way it is. So give me a second here. This is actually a really good slide. It's going to help us with STEMIs. So we talked about what a STEMI is. ST segment, elevated myocardial infarction, okay? we start at the top. Those are our normal looking. There's no ST segment elevation. The J point is at baseline. Everybody agree? As we get ischemic, we'll start to see that T wave flip sometimes. That's often an early sign of a problem. And then we slowly, as we go from ischemia, lack of oxygen, to injury, infarct. So we go into the injury page portion, we start to see that J point rise. You guys see this J point rising? A little bit off baseline, more off baseline, more off baseline. Now that J point's way up there. Once that tissue's dead, and everything in the dead's over, we typically will lose all that ST segment elevation. We start to get this bigger Q wave. You guys see how Q waves develop over time? You can have a small Q wave without any real injury, no big deal. But if you get that Q wave developing deeper over time, that typically means previous injury, previous infarction, I should say.
What lead did this be?
It's probably like lead 2, lead 3, just so.
So that's how you would check past.
It can be an indicator. I wouldn't say it's foolproof, right? So, what are we looking for? First of all, what are we looking for in a lead? We're going to look for 2 or more contiguous leads. Some big words here, and I'm going to explain this. 2 or more contiguous leads of elevation, one box of elevation.
One full box, one big or small?
One full small box. Very simple. So I'm going to draw this out here. This is our 12 lead. Okay, get us in here. So this is 1. This is 2. This is 3. ABL. ABF. Is that right? Well, it has to be right. I don't know why I did that wrong. ABR, ABL, ABF. Thought it was wrong as soon as I did it. ABR, ABL, ABF. This is V1, V2, V3, V4, V5, and V6. Okay, standard 12 lead right here, right? Everybody good with that? That's what that sucker looks like. What we're gonna do is we're gonna help you identify right here what leads. When we look at this, what each one of these is looking at what part of the heart. That defines contiguous. So when we say 2 or more contiguous leads, contiguous, not continuous, contiguous. When we're looking at this, we need to make sure that we're looking at the same part of the heart. So lead 1 is the lateral wall. Lead ABL is the lateral wall. So I want you to draw this out on whatever paper you got. And I make a little line back and forth like that. Those are contiguous. Meaning I need elevation of 1 box or more in lead 1 and 1 box or more in lead ABL to have contiguous leads there. Lead 2 is inferior. Lead 3 is inferior. And AVF is inferior. And I need 2 or more of these contiguous leads. So I draw this one a little funny. 2 or more of those contiguous leads, excuse me, to have an inferior STEMI. 1 box of any 2 of these 3, and we have a STEMI. Well, we may have a STEMI. Let me back up, but
You're gonna have to start all that over, I'm trying to draw
They're about to say.
that's okay. Sorry. I'm gonna say it all again. So if you just want to draw the chart while I talk, I'm gonna say it all again.
What's the lateral one?
ABL is lateral and 1 is lateral.
So looks at this side of your root.
It's the lateral wall.
Then,
This is inferior, 2, 3, and ABF are inferior.
what does it say under the ABO box? Under your little.
ABF,
ABF, I can't.
2, 3, ABF. It's alright. My handwriting sucks, we know that.
No.
My problem in the box.
It's okay. Sorry. Guys, I promise you, I'm gonna get you some mnemonics to help you with this. We're gonna get through this, okay? Sorry, just deep breaths. Bear with me. I'll get you there, Willie. That frowny face. There you go. All right. V1 is septal. And V2 are septal. They're contiguous leads. V3 is anterior. And V4 is anterior. They're contiguous leads. V5 and V6 are also lateral. We're gonna finish this up here in a second, but I'm gonna let everybody catch up before I talk anymore. Contiguous leads. Don't worry, man. Don't worry. I can see you stressing. I got you. We're all par, just kind of look up at me. We are missing one. ADR, we're just gonna kind of put an X at, that's a next week problem. That does not immediately identify STEMIs. It does help us out in the future in some more advanced cardiology. This is beginner cardiology.
So ABL is the lateral.
ABL is lateral, and one and ABL are lateral. V5 and V6 are lateral.
What are the arrows indicating?
These are indicating our contiguous leads, meaning they're partnered.
They're taking the same.
We need elevation here and here to be a team. Here, two of these three need elevation. Both of these need elevation to be a STEMI. The interiors are paired and laterals are paired here. We're gonna kind of add a few snippets in here in a minute.
So let's say you had elevation B1, lead to B1, B3. Since none of those are contiguous.
Yeah, that won't even happen. What you just said won't happen. We'll get there in a minute. I know what you're saying though. You're saying, what if I have elevation here and here, but they're not contiguous? That don't count. Okay? Or let's say here and here. That's
Specifically for a STEMI, correct?
we're talking about status, yeah.
Okay, so what you're saying is if two are paired together, then that's the only way that it can equal STEMI.
Yeah.
So that one's.
Right, and we're not quite got this all flushed out, but yes.
So if you have 2, 3 to ABF, that's inferior wall.
2, 3 and ABF, that's an inferior. If we have elevation, one or more box, and these three, we're doing pretty good on a STEMI. We're looking pretty good. There's some things we have to check. There's these things called STEMI mimics that we're going to go over more this week and again next week. But we're looking pretty good on a STEMI. Now, if there's some other things, some reciprocal changes, we're looking even better. But we're not quite to reciprocal changes. I need to get everybody caught up here. There's a mnemonic for this that goes in order of the thing. You remember this. This lateral, inferior, septal, anterior, lateral. Because it's hard to memorize this. And I'm going to say this a million times. And you're not going to like it. It doesn't matter. I'm going to make you say it. Just like I made you call it the 300, 150, right? That was annoying. But everybody knows the 300, 150 model now? Okay. We're going to do this over and over. It's Lee, L-I-I. Lie, we just noticed, skip that one. Lee, lie, ass backwards, S-S-A, all, A-L-L. Lee, lie, ass backwards, all. You might be like, that sounds stupid. I don't care. Lee, lie, ass backwards, all. Go ahead. Lee, lie, ass backwards, all. There's some other weird mnemonic, but I can see all these. Andrew can teach that to you later. I will tell you right now, I still, when I do this up here, I'm like, Lee, lie, ass backwards, SSA, all. I do it in my head almost every time. It's how I learned it. It's how you're going to learn it. We're going to memorize it. And then we're going to be able to write this up every single time. And at 2 or 3 in the morning, when your brain's not working, you can't think of what you're supposed to be doing, you'll say, Lee, lie. I don't care if you draw it on the thing. At first, you might always draw it on the thing. Eventually, you'll get good at this and it won't matter. But it's Lee, lie, ass backwards, all. One more time. Lee, lie, ass backwards, all. Goes right in order. If you remember that, you know where your contiguous leads are because you know which leads what. So these laterals, contiguous pairs. We see elevation here, we might have STEMI. I'm going to keep saying the word might because we got some other things that we're going to go over. We got 2 or these, 2 or 3 of these, we might have a STEMI. We got these 2, we might have a STEMI. I'm going to draw a little squiggly line here because these 2 are complicated. You can get bleed over from the anterior and septal wall. But these 2 boxes, no matter what, this one requires 2 boxes of elevation, and this one requires 2 boxes because these have both B2 and B3 have some normal elevation. Everything else only requires 1 box, but if you touch B2 or B3 in the STEMI, you need at least 2 boxes. Okay,
These two boxes
of
of,
elevation at the J.
you need two boxes or you need two?
2 boxes of elevation if you're using V2, either with V1 or V2, this needs 1 box, this needs 2.
Two boxes or two QRSs?
2 boxes of elevation at the J. 2 small boxes of elevation off the baseline at the J.
Yeah, but you only got one box of E2 on the strip.
I don't even know what
So
these
how are you
are.
gonna get?
You're getting crazy. No. Not leads. You're talking about leads. I'm talking about the little tiny square boxes at the J point off the base. So
Oh, you're
Come here,
talking,
bro.
it has to
come
have,
here. Come here.
yeah, it has to have two boxes.
2 tiny boxes of elevation
Got it.
off the base. And you got crazy for a
I
second.
thought you were talking.
We almost lost them all.
I thought we were.
No, you're good. So, no, yeah, just if you no, what's he saying? No, okay. Alright, so if we have a septal semi, what do we need? Somebody help me out. We need V1 to have how many boxes? 1 box. We need V2 to have what? 2. Can't have septal semi without that. You can have the anterior semi, you need how many boxes here?
2,
And how many boxes before?
1.
Okay, to have an anterior septal semi, you either need 2 boxes here, 2 boxes here, or you need this whole thing and this whole thing. You can have what's called an anterior septal, which it bleeds over. Where it's at is hitting both the anterior wall and that septal wall. Front and the center. At the same time, the left ventricle.
No.
So everywhere besides V2 and 3 would be 1 box. Or
Everywhere beside V2 and 3, you need 1 box of contiguous leads. Correct. Correct. Okay. Let me find the slide I want since we haven't got there. It's not that one. Stand by. This one. This is a good slide. What I need you to know is this is your high lateral wall. I'm just going to write that, and this is your high lateral wall. These are your low lateral walls. If you have a high blockage, you'll see elevation here and here. You'll also see it here and here. Okay? High at 1 and AVO. If it's slow, you probably won't. Just, I'm telling you, you might see elevation here, 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 and here. Okay? That's the circumflex. I'm going to put CX in parentheses for circumflex. That's the artery in question. Remember I told you originally, we used to not have to know all the arteries to be paramedics. Now National Registry is asking artery questions. So that's the circumflex artery. Inferior is typically the right coronary artery. I'm not going to put the other one up there because it's typically the RCA. Right, coronary artery. This is a great graphic to come back to. Freaked out. Study this more. It's okay. Right, coronary artery. V1 and V2 are the LAD, left anterior descending. We talked about that a lot in A and P, LAD. V3 and V4 are also the LAD. Do you see why this can bleed over? You can also get, so you can actually get elevation V1 through V6 because that lateral, that circumflex comes off the LAD. So if you have a high LAD occlusion, a high blockage on the LAD, you can get basically everything lit up minus inferior. Because that's the right coronary artery, it's coming off of a different main feed.
Is before LMU.
Yes. So if you have a high LAD, you can see elevation 1, AVL, V1 through V6. Okay, everybody okay with that? Is anybody like, oh God, stop, just stop. Yeah? It's okay if you're shaking. I'm not asking if you're shaking. Say, is anybody like, we need to stop right here? Okay. All right. We're going to talk about reciprocal changes here in a oh, where the hell is that? We don't care about that. Just get off my screen. No. Really? Really? You need to have Andrew reorder this for me. I guess reciprocal changes right there. Reciprocal changes. We'll do that over here. So we have certain leads that are going to oppose each other. This is very important, okay? We have certain leads that oppose each other. It's called reciprocal changes. You don't have to have these, but if you have these, you have a home run. Home run STEMI, okay? So if your lateral is elevated, you can get a reciprocal change of your inferior depressed. Meaning this ST segment does something like that. See how it's up? On this one, same 12 lead, but this is the inferior leads. You might see something like that, where the J point is depressed. If you have reciprocal changes, and it's vice versa too. So you can have inferior elevation. What's going to happen to your, lateral leads? If your inferior ST segment's elevated, what is your lateral ST segment going to do? Thank you. Depressed. That's inferior changes. When you have reciprocal changes, you're almost guaranteed to have a STEMI. I say almost because I don't like always and never. But if you're matching and you have elevation here and here, one in ADL, and you see depression in 2, 3, or ADF, you're probably got a STEMI. Okay?
That's the only reciprocal.
These two are reciprocal changes we're going to focus on. On the front of the heart, this is it. There's something when we get to the back of the heart, a sign, but we're not there yet. This is it for reciprocal changes. Super important. You're on duty, right? Okay. Yes, it is. We may not have class. Soak it in. Okay, so our contiguous leads, 1 in AVL, lateral. Contiguous leads 2, 3, and ADF, inferior. B1 and B2 are septal. B3 and B4 are anterior. B5 and B6 are lateral again. Lead, lie, ass backwards, all. Okay, sounds stupid. I cannot tell you how many times in my career I've been like, oh my God, lead, lie. I literally did it when I drew this on the board in my head. Not for you, for me. Lead, lie, ass backwards, all. Okay? I need you to commit that to memory. Lead, lie, ass backwards, all. It takes 7 times to remember something. Lead, lie, ass backwards, all. You guys say it for me one more time. Okay. I appreciate it. I know it sounds stupid. This is how we nail this into our head. How many boxes of elevation we need at 1 ADL? 1. 1 box of elevation, 1 in ADL. Both. Okay. 2, 3 in ADF. Do we need all 3 of them? No. We need 2 of them. Any 2 works. Okay. How many boxes? 1. B1, B2? How many boxes?
1 for B1, 2 for B2.
Yes. 1 for B1. B2 has some natural elevation. That's what you need to know. Somebody be like, why? I don't know that one. That's the way God made us. You can have a little bit of elevation there. So B2, 2 boxes. B3, B4?
2 and 3, 1 and 4.
Very good. 5 and 6?
1 and 1.
1 and 1. Can we have a B2, B3 heart attack?
Yeah.
Yes, we can. 2 and 2. And normally, if you have 2 and 2, you should probably be looking at B1 and B4 because you're probably growing in that area. You haven't already seen it.
So what view is the septal?
But
Septal view.
you look at the center wall.
Got it.
Okay. Then you have a B6, 1. They're both lateral. High lateral, low lateral.
Yes.
Yeah, we just haven't drawn that line. So I normally do something like this. It just gets confusing. Okay. Could you? Yes. You need to really be paying attention to your other laterals, your B5 and your ADL. I need to be looking for those reciprocal changes. Do you have to have reciprocal changes to have a STEMI?
No.
Is this required?
No.
No. Sometimes we don't get the reciprocal. So let's just say we have elevation in 2 or more contiguous leads in our lateral, 1 box or more. We might have a STEMI even though we don't have reciprocal changes with the depression in the inferior leads. We might have a STEMI. I keep saying might. There's like 6 STEMI mimics we have to check for. We're going to do STEMI mimics in a little bit. We will redo them next week. We're going to check for those STEMI mimics every single time. Okay. There are some places, some doctors will tell you, when in doubt, activate. That's not true for STEMIs. I don't care where you go, what service you work for, that's not true. STEMIs is a small criteria that gets activated. Should you go to a cardiac center with somebody you're not sure on? Sure. Somebody who's questionable, somebody who needs a STEMI mimic that is concerning? Absolutely. If you need to run lines of science because they're unstable, you do what you need to do protocol-wise. You don't activate the STEMI unless they meet the very narrow criteria for STEMI. On the opposite side, strokes have the widest net ever. Everybody gets activated for a stroke. Why? Because we can spin a CT machine around their head and it's no big deal. It's non-invasive. It really doesn't even cost that much. What we charge people for CTs isn't crazy outrageous. On the opposite side of that, a STEMI activation, it's invasive. We're going into them. Now you're like, well, I don't need to worry about that. That's for the cardiologist. If you activate a bunch of STEMIs and you're wrong, they lose faith in us and they stop actually activating. Have you guys seen that? Where the hospitals don't hard activate, they'll do what they call a soft activation, where the ER doc's like, I'll check it out. Page him, but tell him to stand by. They slow play. You know what? You work at a hospital. They do it. We had that relationship with one of our hospitals. It was a problem. And we started really honing down on what is a STEMI, what is a STEMI mimic. We only activate on STEMIs. We'll take people to the cardiac center all the time. There's been times where I'm like, this guy's having a heart attack for sure, but he's not a STEMI. What does that mean? He's either not a STEMI yet, or he's going to be a non-STEMI. Okay, what's the difference between a non-STEMI and a STEMI?
ST segment.
There's no ST segment elevation. We have a positive troponin, and we believe it's cardiac in nature. We can't really know that until they do other things, right? So we're taking to that cardiac center. We're still doing the treatments, which we haven't got a lot into treatments yet. We're still doing nitro if it's appropriate. We're still doing aspirin. We're still doing oxygen. We're still doing fluids. All that good stuff. But this one's less time sensitive because the damage is not occurring like we've kind of stopped the damage. I told you the other day, ran my friend's dad. Went out there, met the crew on scene. He looks bad, guys. Like previous heart history, previous heart attacks, previous stents. And I'm like, this dude looks like he could. I was kind of worried he was going to COVID. I was going to be telling my good friend that his dad died in one of my ambulance. So I was kind of like, let's go, crew. Were you on that? One of you two were on that, right? That's like, yeah, we talked about this the other week. I know we talked about it the other week. It's okay. I want to make sure you hit. So we do all the things. We probably just stopped it with the nitro. We probably were preempted. He had taken like 3 nitro prior to us being there. And then we continued our treatments. And then the hospital put him on all the blood thinner stuff, all the, Prolanta, whatever it was, heparin. I don't know what they did, but they kept him from having the massive STEMI. And then he went into CT eventually. So we gotta know this. We gotta know Levi ass backwards all. We're skipping AVR for now. At some point in our advanced portion of cardiology, we'll come back to AVR.
This isn't even advanced.
Guys, this is still basics.
Oh my God.
So we hit this page right here is our base rhythms. We hit all of our base rhythms, and now we are on the sprinkles, and we need 12 leads for sure. Everybody good with this? Let's do some. That really helps clean it up, okay? We okay? Rose cat? They like to put a bunch of other crap in here to throw us off, so I'm going to blow by this for a second. We're going to come back to things that are weird that we aren't ready for. Because why would we not just focus on some standard 12 leads real quick? But we can't for various reasons. Let's do that one. That one's fairly.
So are we looking for STEMI right now?
We're gonna always look at our base rhythm, Mr. Odell. We're gonna look at our base rhythm. We're gonna figure out what that base rhythm is, no matter what. And then we're gonna identify whether or not we got STEMI. Okay? All right, so this is a good example of a 12 lead that's not my favorite. We have no ongoing lead there. See that? So all we have is a 3-second snapshot in order across time. 3-second snapshots across time. So we don't have a base rhythm that we can see. We have to take our base rhythm. I normally go to lead 2 or 3, 1, 2, or 3, and I look to try to identify that base rhythm, and I kind of look across the leads. Okay. We know just based on lead 2 looks pretty normal. Lead 3 looks a little off. A little bit of axis deviation there. We don't know what that is yet. We'll come back to that. But look at lead 1 and 2. Do we have P waves? Do we have QRSs? T waves? PRIs look equal and normal? RRs look regular? What are we in? We got to look at rate. It tells us their heart rate's 86. You guys see that right there? Heart rate says 86. Double checking. That's 300, 150, 100. Yeah, it's like 86. Sounds good. Okay. So we're in normal sinus rhythm. Let's check out the next thing I do. So I got a base rhythm. What's the next thing we do? Before we go into STEMI world, what is the next thing we do? We check V1, right? Look at V1 for width for that bundle branch plot. So we go to V1, like this is order of operations. We determine the underlying rhythm. Whether we had a 3 lead and we did it on 3 lead, or we went straight to a 12 lead, I don't care. We determine the underlying rhythm. We just did that. Next thing we do is we go to V1 and we look at our QRS width or QRS duration. It tells you right here, our QRS is 0.1, less than 0.12. We agree? Narrow QRS. We're not in a bundle branch. Okay? Do you see where it says incomplete right bundle branch? I hate that it even says that. I know why it says that. It's saying it's getting near. It's almost to the threshold, but it's not to the threshold. So don't confuse us. Black that out, okay? Now, it says a whole bunch of crap there. Acute MI, abnormal EKG, normal sinus rhythm, incomplete bundle branch, ST elevation. What I need you to know, the doc in the box is not smart. It casts a wide net for this criteria. If it sees certain things, it's going to activate the big alarms, which is what it's doing. Your job as a paramedic is to see the big alarm and say, what is it seeing that I'm missing? We haven't even looked at this. I don't want you guys to, don't get ahead. We haven't even looked at this rhythm for ST segment elevation. I see that alert, and my first thought is, well, A, is it real? Okay. I'm going to run my algorithm to say, is this a real STEMI or not? And then when I finish the, is this a real STEMI or not? My next question, if the answer is no, what is doc in the box seeing that I'm missing? Because it's alerting for some reason. So why is it freaking out? And what am I not seeing? Okay. I have had one time the doc in the box in my career, it said acute MI, like losing its mind. And I was like, nah, it's not a STEMI. And then I did my next process, like, what am I missing? And there were some really subtle changes. It was really early in this man's STEMI, and I did a repeat. And I did a repeat. And then I was like, it caught it before me. That's what happened. It saw acute changes that did not meet one full box of elevation, but there were some inverted T waves. There were some things that were concerning. And the big net that it cast said, this could be a STEMI. I hope this qualified clinician, where does it say that? It says it on every single one. It's probably cut off. It should say, must be reviewed by a qualified. You are the qualified clinician. Isn't that crazy? You, paramedics, will be the qualified clinician that says, yeah, it's a STEMI or no, that's not STEMI.
So can you confirm and diagnose a STEMI?
The word they don't like the word diagnose for
I know.
paramedics.
That's why I'm asking.
You confirm your STEMI, you call your STEMI alert, and you stay confident about your STEMI. So when you make a decision, you say, that looks like a STEMI to me. Because I've taken the course, I know the knowledge, and you don't have that today, but you're going to get there. By the end of this program, you're going to say, that's a STEMI. And you're going to be confident about it, Josh. And you're going to call it confidently, and you're going to be wrong probably once or twice, and you're going to learn from when you're wrong. Maybe it was a STEMI mimic that you missed. The thing is, by the time we get to the end of this, you'll know all your STEMI mimics. Right? And you'll know what a STEMI is and what a STEMI isn't. And then you're going to use that. And if they say you're wrong, sometimes they do this. This is really funny. This cracks me up. Actually, it makes me irate. But they'll do this thing where they'll cancel you. They'll be like, that's no STEMI. No. You know, it's cancel code STEMI trophy. I leave, I get my little ambulance and I drive away. Go back to the station, I pout and I fret. And I do this thing a couple hours later where I call up there and get a feedback check, just checking up on my patient. Yeah, we reactivated it. And he went to cath lab 3 hours later. I'm mad because they should have listened to me. I'm overjoyed because I was right, because pride, right? But I'm sad for my patient because that's 3 hours of injury they probably didn't need to have. Okay, that happens way too often that they cancel STEMIs. The ER docs are like, nah. And then they run another repeat troponin, or they get a troponin later, and they're like, oh, that's bad. Yeah. Well, troponin with that elevation that the medic saw that we said wasn't enough elevation, but it kind of was borderline. Now we have troponin confirming that. Oh shit. Now they're going to the cath lab urgently. Okay. So Yes, you can call it. We don't diagnose heart attacks. We confirm a STEMI. We call in the STEMI, we activate the STEMI team. They come in with their wires, scope, check the heart, cath the heart. They diagnose the MI because doctors diagnose. Which is fine. We just point it out. Alright, we're like, hey, this is bad, doc, and this is what it probably is, and you get to say yes. Alright, we look at this differently. Everything else we kind of look at in order. We're gonna look at this in order of contiguousness. Contiguousness, is that word? I don't think so. By lead style, by location. So when we look at a 12 lead, we've already got the base rhythm. We've got V1 is narrow. It's not a bundle branch. We're gonna look at this now by location lateral. Do we have ST segment, J point elevation of 1 box or more in lead 1?
I can't see the small way.
So you look at your closest TV. There is some elevation there. Looks like it could be a box, but maybe it's real close. Go to AVL next. So you got 1. Now you go to AVL. Do you have a box of elevation at your J point? Okay. Well, remember, we're not looking at just 1, but we're looking across the way to say, does it look like it? 1 and AVL are real close on elevation. Are we good with that? Now we look at 2, 3, and AVF together. We have elevation or depression at our J point. Remember, it's not the whole segment because a lot of times where it turns, it's lower or higher, and then it kind of slopes in one direction or another. So let's look at 2. This is the J point right there.
Yes.
We have a box of elevation. This is a J point right there. Yes?
Yes.
So we have, what is it? Elevation, depression?
Depression.
Got depression. Go to 3, or go to 2. Find your J point, where it starts to turn sideways. These are hard for people to find. Even senior medics struggle with J points, where it starts to make that turn more right than left, or more right than up. That one may not. I think that is. Okay, do we have elevation or depression? Depression, go to AVF is a lot more clear. Where it turns sideways is a lot more clear here. Elevation or depression?
Depression.
So you're saying we have depression in 2, 3 in AVF, and it looks like we have a box of elevation in 1 in AVL. Right there, we're gonna check this whole rhythm, trust me. But right there, this is where we get into home run stuff. Right there, do we have a home run? Does it feel like a home run?
Around a third.
Elevation in the lateral leads, depression in the inferior leads. We're gonna check this whole thing, but this could be a home run stemming.
Oh.
Let's go to V1, V2. Remember, we're looking at these by pairs. Lead line, ass backwards, SS. Do we have elevation in our septal leads at the J point, starting with lead V1 of 1 box or more?
Yes.
Yeah, that's
Both
tricky.
are.
Yeah, you're right. We have elevation. We're seeing 1 box or more up there. Let's go here. Do we have 2 boxes or more?
Yep.
Yeah, so remember SS. So now you're saying we have 1 in AVL, we have SS. Let's go V3. Do we have 2 boxes in V3?
No.
No. Okay, we do not. Baseline is basically right here. Close to there. We're right there. We have less than a box or right at a box. That's not enough for V3. So we do not have anterior, no. Go to V4. We have elevation or depression.
Not really. No.
Not really. Okay? Not really. V5.
Depression now.
I hear what you're saying. I see it a little bit here and here, maybe. J point is like right there. So it's not a full box. It's close, but it's not quite a full box. V6, where it really turns sideways more, is right there. Okay? It's not great. So we do have 1 in AVL elevation. We also have some septal involvement. Can we have lateral and septal? Can. Both come off of what artery? LAD. Circumflex comes off the LAD. So we can have that overlap there. Where can we not have overlap? Where we would have elevation in both leads? You guys get this? if we have elevation in the lateral, we should not, 99.99% of the time, have elevation in the inferior.
So if you do have that.
That's something else.
Is that two?
Is that the ADR?
That's a mimic.
Oh, okay.
So if you have elevation in lateral, you have elevation in inferior, it's most likely not a STEMI. Because those two are opposite of each other. Same thing, if you have elevation in inferior, you should not have elevation in lateral.
Oh.
They're opposite of each other.
Always be on. Be opposite.
I hate the word always, but yes. Because somebody will find that 1 in a million patient has multiple blockages all throughout their heart, right? That has a massive LAD occlusion with a massive RCA occlusion, and they'll find that 1 in a million. But right now, guys, we're not on that 1 in a million zebra. We're on your normal everyday patient. You're not going to see this.
What do we have? Standard criteria then?
So we have met our STEMI criteria. We have actually met what I call our home run STEMI criteria. And we have a heart attack. Yes. That says regatta up there. That's a different thing we're going to get to later. But yeah. Yeah, we were there. We were there. Let's try to find another example to look at a standard STEMI before we start looking at any of these mimics and confuse the shit out of everybody. Okay? What is this about? QTC. We already talked a little bit about QTC. We're not going to jump all over that yet. I gotta find some good STEMI pictures. Hold on a second. I might have to pull up another PowerPoint just to fix this. But I know there's some more in here that are.
Why don't you just like Google this?
I can, but yeah, I might be able to. There's some in here, but I just have to get like halfway through the data slide set. All right, let's do this one. This is a good one. This is a really good one. Let me pull this up for us. Stand by one. All right. First of all, before we do anything else, bass rhythm. That's a lead 2, an ongoing lead 2. We love this kind of 12 lead. It's good for us. What is the bass rhythm? Do we have P waves?
Yes.
We have QRSs?
Yes.
QRS is narrow or wide? Narrow. R to R's are regular. Okay. Rate 300, 150, 100, 75, 60, like 58. So that is
Simon Brady.
sinus Brady. Everybody good with that bass rhythm being sinus Brady? Next thing we do, we go to V1, we confirm that we're narrow, we're not greater than 3 small boxes, and we're not, which means we're not in a bundle branch block. Thank you, because we could have some blockages, but that's different, right? So we're not in a bundle branch block. We look at 1 and AVL as a team. Elevation, depression, nothing at the J point. What do you guys see?
Pressure.
Yeah, actually, I'd say more than slight, my friend. J point starts right about there-ish.
Yeah.
And then it just keeps dropping its bottom out. It looks like the T wave's inverted. That can be a sign. You're like, well, is that the T wave? I think that's just it coming back to baseline. So I think we have inverted T waves there. I'm actually not 100% sure. It's close. I'm not sure if that's an inverted T wave or we just have that much depression coming back to the T. I'm not 100% confident. When I look at 1, I think those are just T waves. So that's probably the same in AVL. Anyway, look at 2, 3 in AVF. Do we have elevation, depression, or neutral? Elevation in 2, yes. 1 box or more, maybe a box and a half. Elevation in 3, like what, 5 boxes?
Depression.
You see depression in 3?
Or elevation.
Elevation in 3. If you saw depression in 3, I'm going to have you come up here and tell me. AVF? There's a lot there too. Tyreek, you all right?
I think I'm good.
You sure?
Everybody goes a lot faster.
Come up here and show me that elevation. Come on. You be all right. I ain't picking on you. Draw and see me. Show me the elevation here in 3.
The fact that you think I can reach that.
Point to the J point. You got it. You got it. Point to the J point. Where's the J point now in 3? Any one of those beats.
So,
Oh, you want me to point? You really can't. Where do you want which way? Right there? That's J point. So that's where we measure our elevation from this baseline right here. We say that's our elevation. I'm not picking on you. Same thing here. That's our elevation. So we got more than 1 box in all 3 of those leads, yeah? So we're looking really good because we have you got inferior elevation. You got inferior elevation with lateral depression, right? Yes? Am I making this shit up? Yeah? Okay, thank you, Carney. Appreciate it. You're not Carney, that's him.
So that's
Brady.
kind of like a
That's your team.
big, clear example.
This is very clear. This is
Yeah,
this is bad. This is what we look at as an inferior STEMI most likely. We do have to finish it. You can't quit there. Some people will grab that and then just be like, look,
I'm not trying to question.
why can't we quit there? I want to make sure we don't have. I want to make sure I'm not messing up. I want to make sure I'm not missing a STEMI mimic. Really, is the number one reason. So I got to look across the board because if I could see, yeah, I want to make sure I'm not missing STEMI mimic. So I'm gonna look at V2, V3. V2, do we have a box? Oh, I'm sorry, V1, V2. Gosh darn it. Do we have a box in V1?
Yeah.
I think we have a box in V1. But we go to V2 and do we see any boxes in V2? Not the two we need for sure. Okay, V3?
Yeah, probably one.
Probably one, but not necessarily two. V4? Looking across the way, the whole thing? I don't see any. The second beat, like you're like maybe, but you can look at the first beat, the third beat, like not really. All right, V5 and V6? No. So we're just looking at what we would call an inferior STEMI. Now this is the first inferior STEMI we looked at. What I need to know, what we see in inferior STEMI, that's what we're looking at is the bottom of the left ventricle, that bottom corner. We need to check the right side. Because that could be just a standard inferior STEMI, or it could have what's called right-sided involvement, which means we're going to check the right side of the heart. We talked about that. We're going to move V4 over to V4R. If we have elevation there, we have right-sided involvement. Why this matters is if we have right-sided involvement, our blood pressure is going to be very sensitive to nitro. Remember, strong side,
Left side.
left side. Weak side, right side. So let's say we have a borderline blood pressure. First of all, your local protocol is going to depend on when you give nitro. Let's hear some protocols on when we give nitro.
Over 100 systolic.
Over 100 systolic. JCAT, I think we're at 110 systolic. It's somewhere in that range. I doubt anybody's 90. I hope not. Okay. A standard STEMI, you could drop 10, 15, 20 points systolic drop with nitro. Not such a big deal if you're at 110. Even if you're at 100, we can get down to 80 and we're okay. We can give some fluids. If you have right-sided involvement, you can drop 40 points pretty easily because that's the weak side. We need it depends on what we call preload dependent. It depends on that preload coming in. So if we drop the preload, it don't work well. I'm gonna get to both of these questions. Give me 1 second. So we have to be careful. Some people are gonna say this is wrong. So once again, turn it off, turn it back on. Well, if it's an inferior, I know inferior, we just don't give nitro to inferiors. That is wrong. Hear me, that is the most wrong thing you can do. If they have a blood pressure of 160 over 90, and you're just straight up not giving it, even though they can tolerate, first of all, they can tolerate a 40-point drop. Second of all, it may not be right-sided involved. Check the right side, see if it's right-sided involved. If it's not right-sided involved, you can still give nitro, just do it cautiously. Have fluids ready. Be ready for a 20-point drop. It's okay. Not giving nitro to a patient that needs nitro because they're having a STEMI is zero. There's one thing we can really do. We give aspirin. What does aspirin do? Does it stop clots?
No, it's just keep platelets from being so sticky.
Yeah, that's a good way to say it, right? Keeps platelets from clumping as easily. It does not do anything for widening the blockage. If the blockage is here, and they're 99 or 100% occluded, the number one thing we can do if our blood pressure will tolerate it, if we're not afraid, is to make it like this, so some oxygenated blood gets through. That's the only thing we can do, is make it a little bit dilated so some oxygenated blood gets through so Mr. Smith doesn't die in our ambulance. But if we're too afraid of our shadow, because one day some old medic somewhere taught us that inferiors we can't give nitro to, that is just wrong. You can, you should be careful. You should check the right side to see if they're right side involved first, especially if they're narrow on the pressure. Narrow on the pressure means close to your threshold. Maybe within 10 to 20 points of your threshold. If they're nowhere near your threshold, I'm still going to get a right side 12 lead, but I'm not going to be so hesitant. If they're at 160 or 110, I'm not even concerned. I want them to come to that 40 points. That's fine. So if they drop 40 points on one spray, though, you don't think I'm going to do a second, do you?
No.
If we're at 110 over 60, and they're right side involved, do you think I'm going to do one? No, because I don't want to deal with 70 over 30. Is everybody, like, it's super important everybody's tracking? All right, I got a few questions. Brayden, you had a question?
I did,
Yeah, I'm
so,
sorry.
do you know it's an inferior because the inferior leads are the ones?
Yes.
elevated?
Yes.
Okay.
Nate?
So now you move B4 to B4R, what's that gonna look like up there with this?
It'll look just like this, except for if B4 is involved, it doesn't say R, you write R, you physically will write R on there. It'll look like maybe this.
It'll have
You're
elevation.
gonna have elevation. So when, and nobody ever explained that to me, right, guys? When you do a right-sided, when you just flip a V4R over, do you look at the whole 12 lead? No. If you're just doing V4R, you move V4 over the V4 over here, and then you're really just looking at V4R to say, does it have elevation or not? And that's a cheating mechanism. You can do the whole standard right-sided, which we talked about a little bit last week. We'll talk about more next week. You do the whole standard right-sided, then you're looking at all those leads basically to say, do they have elevation? But they're all looking at, all your view leads are looking at the right side of the heart. Real quick.
Serious stimulus at 110. You be able to give saline and nitro and kind of cancel out, or is that
Do they have right side involved?
no?
So this is a no. They're at 110. I would have fluids going and I would consider a spray.
So if it's
After you check
right-sided-
these-
I would prefer it be a little bit higher than that, just to be quite honest.
Okay, so can you sit there and can you do
Yes, you can wide open bowls.
I know, but then I'm saying instead of doing, all right, let's get your flawn and do a spray, you get them flawn and say, let's get up to 130 before I give you.
I would doubt you're gonna get it. I doubt that a lot.
So, just talking about, I guess, right side involvement and stuff. Will your pressure drop because although you're opening things up, it's not giving enough blood for the heart to pump, so that's why it's.
It's a preload problem, right? There's not enough coming in. Remember that right side is weak. It needs the push from the left side. If there's not enough, when you open up, when you dilate everything, there's not enough volume coming from the left side when it gets to the right side, it doesn't do well with that. It's already a weak heart. Now it's even weaker because it's damaged. And now you don't have that flow coming in to prep, you know what I mean?
Okay.
So you're relay pumping. You got an old time engine that was the first two on scene trying to make the pump to the lungs to push to the fire. The new engine's behind it. Okay? The new engine doesn't have enough pressure. All of a sudden the hose lines are weak, right? Your pressure's down. That 1970 pumper that you have up front, the right side of the heart's sucking. It's not doing any good. So all of a sudden you lose everything. I don't know if that's the best example, but I tried.
So like you said, if you wanna be in the protocol, but say it's like way above, right? And then you're saying that you need to switch to the right side before you would like do anything to give nitro, but like if it's not within that range,
Yeah,
why would you?
I hear you. Because I want to confirm what I'm dealing with first. And I want to do it quick. I'm not, it's a great question. I want to do it quick to be like, we're getting everything ready, we're throwing aspirin. I just want to get that picture. Because sometimes what happens when you move people, when you do things, that picture changes. So this is like, we haven't really talked about this. Okay, we're here, we're on scene, everyone on scene. Hey, Mr. Smith, my name's Nick, this is my partner, Nate. We're gonna check some quick vital signs. Nate's gonna get you hooked up. Are you allergic to aspirin because you're having some crushing chest pain, right? Yeah. Let him tell you the story, don't give him the words. Crushing chest pain, okay. Hey, are you allergic to aspirin? No. Go ahead and like I'm talking about the first first 3 or 4 minutes on scene. Chew these up, chew these up real quick. Nate's got 12 lead, what am I doing? What's my job now? Because I need one thing before nitro. Well, two things. Good point, man. I need an IV, I need a blood pressure. What do I need the IV for? If I tank their blood pressure, I may not be able to get that IV, and I want to be able to fix my problem. Most protocols say nitro with caution without an IV, and they suggest an IV first. I'm telling you my rule of thumb, I've done it once in my career, it was an accident, I just got ahead of myself, and then I realized what I did, and I was okay, but I always get the IV. Get the IV. So Nate's hooking up 12 lead. It takes a few minutes to hook up a 12 lead, get a blood pressure. It takes a little bit of time for that blood pressure to run. If I'm good, and I don't like starting IVs in the house yet. I don't enjoy it. It's not my favorite. I like my work side space. I like to have everything set up. But in these situations, especially if he looks sick, we'll start that IV right there. Get it secured, ready to go. 12 leads done. Hey, I'm looking at it. IV's now done. 12 leads done. We've already given aspirin. Oh, that looks bad. Hey, are you allergic to nitro? Have you taken any nitro? All right, it's going to go into your tongue, whether you're doing a spray or a tablet. Okay. What if they've already taken nitro?
When was the last time you took it?
When was the last time you took it? How many did you take? I'm not that worried. Our protocols here say we can go ahead. But it's really about blood pressure and when was the last time you took it? Took it 3 seconds ago and it's a tab, no, that's still working. They took it 10 minutes ago, I'm looking at doing another one already, okay? We also have nitro drips at JCAT. So for this JCAT folks or anybody that hasn't, who has nitro drips? Anybody? They're great, they're good. I'm still gonna give my spray. So I'm gonna,
Good question.
it just buys me about 10 minutes. It's an immediate fix to a problem. That nitro drip takes me 3 to 5 minutes to set up. Probably shouldn't take that long, but it's gonna take me that long. Because I'm gonna tell you, that came on the truck after I stopped working every day. I have to play with that same thing a little bit. It seems silly, but you gotta get the pump out, you gotta hook it up. The tab comes off, it's a glass bottle versus the things we're used to. You can do it, it's fine. It's a great drug and it works great, but I'm gonna get them going on the perfusion. Some of these people will die before they get to your drug. How terrifying is that? I've seen it happen. They are so blocked up, you get there, you make them exert themselves from there to your cot or whatever it is, and they die in 12 feet. Don't make these people exert effort. If they look like the textbook picture of somebody that's dying, and they're having crushing chest pain, you do all the work. Don't even make them try to stand up. Like you're gonna Mr. Smith handle them to the cot as gently as you can and protect them because they will die. And it might take you the first one doing it. I was a young 7-month part-time EMT, and we had a guy that looked like death and couldn't get the cot in the door, this, that, the other. Oxygen tree, back when you had to screw on the stupid tree things, wasn't on the thing. We had him walk 7 feet to the cot. By the time we had the cot in the ambulance, he's dead. We were doing CPR. Eyes twitching. So be careful with these people. They will die on you. All right, we good on this one? Oh, did we walk it across? We walked it across, right? This is an inferior STEMI, 2, 3, and ADF. We have reciprocal changes, it makes it a home run. Let's see if we have any other good 12 leads here. We'll do a bunch, but I'm gonna have to go through the other things in this slideshow too, so. I appreciate that. And we'll pull up a bunch so you guys aren't struggling with this. Oh my goodness, who cares? This is the stuff I don't like to teach because it's all the extra stuff that like I feel like we've talked about already to an extent.
So you were talking about this aspirin, nitro and all that stuff. And still oxygen.
So oxygen, yeah. I don't think I'm gonna get any more in here. It's ridiculous.
Because ours used to be oxygen, aspirin, nitro, morphine.
Yep.
Now we're not doing.
So it used to, and they'll talk about that at some point too. The acronym was MONA. Morphine, oxygen, nitro, aspirin. Morphine was for pain management, not necessarily in that order. My goodness. But morphine has fallen out of favor quite a bit. Morphine did have some benefit of the dilation effect. So the dilation effect in morphine creates a little bit of the same thing as nitro, but not a lot. But a lot of places aren't using morphine as much. Morphine's a little harder to titrate the pain control effect. Where fentanyl, we can really dial, I don't know, I feel like we can dial in our pain control a little bit better.
Morphine what?
Go ahead. I feel like morphine's a little harder to find the perfect what number to give. So you have a range of 2 to 10 on morphine. Most places is 2 to 10 on a dose of morphine. 10 is a very heavy dose. 2 is a pretty light dose. I used to equate like 25, and I'm not sure there's any science here, so this is me talking, not the textbook, but 25 of fentanyl to about 2 or 3 of morphine. Okay, so 5 of morphine to about 50 of fentanyl. 10 of morphine is at least 100 of fentanyl, like that in that comparison. I think 10 of morphine hits a lot harder. Morphine also has respiratory effects. So if you give 10 of morphine, you should expect your patient to have respiratory depression, not breathing well. You give 100 fentanyl, typically we don't see that. We don't see the respiratory effects. All right, I'm gonna go back to where I was. Everybody doing okay? You guys need a break?
I'll go pee real quick.
Go take a break, give me 5. Come back, I'll find the right slide. We have to go over these STEMI mimics.
Oh, really?
Yeah.
I've said it multiple times in the last 6 months. It's waiting less for payment, all I need for.
It's such a funny ass response.
We could go get somebody to laugh. We're going to class, I'm shooting my game on the phone. I got my hit. I gotta call the hospital.
So everybody else genuinely, you guys, I know it's all right. Actually, I don't want to ask that whole left side of the room, I feel like. They look like, are you good? Look, you're not good, thank God. I'm not saying thank God, isn't like I want you to fail, but I want someone to fail along with me. That way I don't feel as.
I thought I was doing pretty good, but.
I thought I was doing good and then I wasn't.
It's
You know,
not-
I thought it goes so fast and like. I'm
Dude, that's enough, like when we're going through it, he's going so fast and I don't know if I'm even understanding him.
I stopped him when he was drawing because he kept talking, but I'm like drawing my box, you know?
Yeah, I think the other reason I learned the prelude so well is because it's coming in class next day, so I've done that. But I'm definitely have to be careful before you turn on the shit. I looked at different mnemonics and now I'm even more confused.
Like this is making sense to me, obviously, but I forgot the bundle branch.
So it helps that he throws the colors on.
Yeah. I just took
Like
the
on
picture
that.
that we had.
Yeah, off of this.
Yeah.
Yeah.
I just took the picture and put it on there and then I drew on it. That's helping me. But even that's still not.
Oh, you like kind of screenshot it?
Yeah, screenshot.
Oh, yeah,
And I just- Can you write it?
I have a really long one.
Yeah. That's because your other one's supposed to read, right?
I did.
Looking at that. It's still screenshot on there, but if you have your mouse on your computer.
I could always take a picture of my phone.
This is helping me a lot, like colors.
Because you're inferior.
Oh, I wanna look at this.
This color coded all over, so you can just sit here. Oh, there.
We're not supposed to like look at videos yet until next week. That's when we can go and look at that stuff.
Oh god, that's so small.
Something that helped me though is, I'll go on ChatGPT and I'll say, explain this, and I'll explain it, and I'll say, now explain it for a 5-year-old. And then just look at the words like, now explain it to me like, oh, now explain it to me like I'm two. Explain it to me like I'm retarded. And then it does. And one of the examples it gives, your heart rate is wrong. Each read is a microphone. We get with these. I have some that sound a little raspy. That's when you notice validation. Oh, that kind of makes sense.
And then my problem is.
Oh, he's not. At least to me. He's like already on the next part. I'm still trying to find the J point. I'm so looking like, is the J point right here?
I understand.
Dude, I was looking at the T-wave, but you were going
Dude, I was like, he's like, point out the J point. And I'm sitting there and I'm stressed out. I'm like, I can't reach it.
You tell me the window, you're looking over, okay, six.
Oh, sure.
Fuck.
All it was my patience.
Telling you, dude, I just gonna keep Bibles in my backpack, same amount.
Hey, what about the restart? Yeah, holy water just splash them every time you get it.
Just get saline and just spray it at you.
You leave line at backward.
I need a fourth color.
Yeah, see, but like,
The other mnemonic was.
why?
I need a fourth color.
I think I'm spoiled. Because the EKG you're talking about, that's like beautiful, that's all you have to look at. So then you pull up like an EMS one.
Yeah, it's not the same.
Like this.
Yeah, you're gonna have some adjustments.
Is there a way to turn that on the monitors?
No, it's monitor specific. So what do you guys have?
15s. Going to the 35s.
Yeah, I don't know if 35's have it or not. But it's nice, like our temperatures have it. Yeah, ongoing, well,
Your read through.
I say that, but also no, because we get a screenshot, like we can't print them anymore. Oh, it prints, not prints, never mind. We can't print through the, like why that is, that pisses me off. It's asinine. I lost that stupid thing too. It does, it makes me so mad because like, I want to see it, I want to be able to navigate what I'm looking at. And so it's hard to do when you can't, when I talk about looking at blocks and trying to print a real long strip, I can't do it, right? I'm just looking at a little snapshot. Okay. Do I? All right, so we're gonna skip these little blocks for this week. We're gonna get these little blocks next week, but this is little stuff. We're not super worried about these guys, okay? Why it could be like that?
Not usually. Doesn't move, I think is that, like, it's trying to reach.
Well, when it works.
It's trying to follow you right now.
So at least now I can get it, like, hey, where you at? Should start flashing. Hey, friend. This way. It's kind of creepy. So creepy. Anyway, we'll get into these little blocks probably next week, but really what you need to know about these little blocks is when we have a bundle branch, we have some of these other blocks that we haven't really talked about yet. These go along with axis deviation, which we haven't really talked about yet, and that's okay. The more of these little blocks, little electrical blockages we have, the more like we have a bigger problem. But we'll get there. We'll get there. Don't freak out. All right. We're going to start talking about stemming mimics. So what I need you to know is our first stemming mimic is the bundle branch block, which we already went to. What is the bundle branch block?
B1 that's a wide.
B1 is wide. Okay. If it's a right bundle branch, it's more up in B1. If it's the left bundle branch, it's more down. Carney, you good? Braden? Okay, cool. Why does that look like a mimic? I'll show you in a minute, but you can see it starts to look like we might have STA segment elevation in those leads, so it can be a challenge. We get into these atrial abnormalities, whether it's left or right, atrial. I'm not going to freak out about this, but what you see is you start to see how they're running into each other? You see that here? V2 is running the S wave, running into the V3 wave. They're running into each other. They're on top of each other there. Okay, that starts to mean we have some atrial abnormality or hypertrophy. I'm going to show you here. LV or hypertrophy is probably our best. So we're going to put that here. Number 2 on stemming mimics is hypertrophy. What is hypertrophy? Stronghold. Too muscular, right? Okay. Too muscular. The heart's too muscular. Whether it's left or right, I don't really care. You could diagnose that, but you start to see these massive. In this case, it's R waves, large R waves, V1 and V2 here. A lot of times they'll even run into the other one. You say, well, why does this cause stemming mimic? Well, like V2 looks like it's depressed there. Do you guys see that? We have inverted T waves. It starts to look off. And so then if you have another lead that looks like it might have a little elevation, it can become confusing. Well, it's let's not use the word strong. Muscular. It's too muscular. It's too thick. Got thick over time. This is left ventricular hypertrophy. So we just did right. That's the right side of the heart. Here's the left side of the heart. We start seeing these large S waves in V2 and the V3. They start to run into each other. Let's analyze this rhythm across the board. Let's start with our underlying rhythm. Do we have P waves? PRIs are equal and normal. RRs are regular. We're in some sort of sinus rhythm. 300, 150, 100. We're in a sinus tach. It's a little over 100. Everybody good with that? So we're in a sinus tach. Let's analyze V1 for QRS duration or QRS width. From the J point, which is on the thick line. I'm looking at this beat right here. From the J point, which is from the beginning of the QRS, which is kind of on that thick line to the J point. Looks like we're right at 3 boxes. I'm at V1. 1, 2, 3, fourth beat over. It kind of lines up with that thick line. So I'm going from the thick line to where the J point is, where it turns sideways. And I'm saying that's 1, 2, 3 boxes. 3 small boxes. So is it too wide? No, it's right there, right where it needs to be or less. Okay. So we're not in a bundle branch block in this case. Okay. We're going to start with 1 in AVL. Elevation, depression, or neutral in 1. Pretty neutral. Remember, we're not looking at the PRI for baseline. We're looking at before the P wave and after the T wave for our baseline. And that looks like it lines up pretty well. Okay. Going to AVL, same deal. We go with neutral? Okay. 2.
Nope.
You say no. We got some elevation there. Okay. This is a good example of something I kind of call cupping, where it kind of U's. There's not a good J point, and that U'ing of the J point is kind of elevated up the baseline. We're going to get to that in a second. Let's look at 3. Does 3 look okay? I think we're okay. I hear you. Let's look at ABF. We okay at ABF? Okay. So 3 and ABF are good. 2 might have a box. Does that matter if 2 has a box now? If 3 and ABF are good? It does not matter. It could have 4 boxes. I would ask questions if it had 4 boxes. But if 1 has it and the other 2 don't, it doesn't matter. That's what I need you to know. So ABF, any combination, you have to have two elevations. Yep. V1, elevation, depression, or neutral? Really neutral. It has an inverted T wave. Not sure why that is, but it's neutral. V2, need 2 boxes here. No, I'd say we might have our 1 box of normal average elevation there, but we don't necessarily have 2. V3, need 2 boxes here.
No.
So J point's hard to see here. You gotta kind of find that turn right there. That's where it seems like it starts to really turn sideways. And I'd say, yeah, it's not great for elevation. V4?
No.
And once again, we're sloping sideways, but where we turn, V5.
Yes.
Yeah, we have this Ewing again. This is the same kind of Ewing we saw in 2. You guys agree? But we know this is the lateral. Let's go ahead and call V6. Ewing again. Okay? This is lateral. This is inferior. Oh, it's a home run. No, it's not. It's the opposite of a home run. Those two don't pair together, remember? They're opposite. So when they're both up, then it's a mimic. If you have most likely, if you have inferior and lateral, both elevated, you're most likely not in a STEMI. You're most likely in a STEMI mimic. It's just a trick. I almost got you. You're like, please don't walk like that. Not
So like a mimic.
But is there
it was PK5.
But is there anything we're gonna do about it?
Well, it depends on which one it is and what's going on. We don't know anything about it yet. You're talking about hypertrophy? We need to do another.
No, but like if you, in your lateral or both.
Depends on which one we're dealing with. We've covered, this is number 2 on the semi-mimic list.
A mimic won't turn into a STEMI.
No, not necessarily.
Are those things that we haven't learned yet that we will treat, like that it is something?
We're gonna work through them. Let me work through these 6, okay? So this is hypertrophy, okay? Diagnosis is made by an echocardiogram. And what we're seeing is these large R waves. They're running into each other. It doesn't mean much for their output may not be great. The cardiac output may not be great. They're what they call the ejection fraction. The amount of blood shot out with each beat may not be great, okay? We're gonna treat the symptoms. So if they're hypotensive, we're gonna give them fluid. You know what I mean? Like, we're not gonna freak out about this rhythm. We're just gonna treat the patient, not the monitor. Yeah, let's keep going here. We did this, right? We looked at that. Really good slide. If you guys need to review, that's a good slide, okay? What's this say? Yeah, we talked about how to do that already. Good. This is another good slide. So remember that one, come back to that one as needed. We already talked about it. We're gonna approach this just like anything else, and we'll go from there. So let me blow this up first real quick, and we're gonna do our thing. So this is just so you know, we're probably dealing with a mimic, but we're gonna approach it the way we are. Do we have P waves? Underlying rhythm down there. PRI is equal and normal. RR is regular. All right. So we're in some sort of sinus rhythm. Check the rate. Sinus rate. 300, 150, 100, 75. You guys thought this Jay guessing. So normal sinus, underlying rhythm. We go to V1. We always go to V1 first. We look at the width of V1. We say, is it wider than 3 boxes? And the answer is no. Okay. It's not too wide. So we're not in a bundle branch block. Everybody agree? We're not in a bundle branch.
Could you point out the same quality? Are you referring to the QRS?
QRS and V1. It's not too wide. Yeah. Hey, do you have access to that closet? Actually, that closet. Would you grab me that white ladder? I get this out sometimes because it gets to the point where I need it. We're looking at V1 for width.
Yeah.
I'll just come right here because these guys are all queued up right here.
Right there on the wall.
What are we asking? What's the question?
The J point on 1.
J.01. Yeah, this one's good right here. Right there. So I'm gonna start 1 little box. Oh god, that's hard to see. 1 box, 2 boxes. That's kind of in your 3rd box, but it's not even 3 boxes wide. Here, we're starting right here. We're going to right here. See what I mean? Maybe in the back hair there. Actually.
Oh, so this first,
Use that first one. It
it
might
might
be
just in front of the purple there?
right there. See where it kind
What's
of.
worse?
Okay, cool.
Yep.
It's close. We're gonna use it as needed to. So. So we're here. Hopefully my camera doesn't get lost. All right, so we decided V1 is all right. We do not have a bundle branch. So we look at 1 and ABL at the same time. Looking at 1 first. Elevation, neutral, depression. Question mark. Neutral. ABL. Neutral. 2.
Questionable.
Questionable. Once again, we have that cupping. Do you guys understand what I mean by cupping? It does this U thing. What we're saying here is, yeah, that's a whole box up at the U. But why is it Uing? We come down here to 3. We have cupping. It's Uing. It's basically at baseline there at 3, but it's still got the Ewing. 2, or ABF also has a Ewing, and it's also basically at baseline. Okay, so we only have it in 2, similar to last time, but we have cupping in all 3 of these this time. we go to V1. Elevation, depression, or neutral.
Where are we at?
V1.
B1? Neutral.
Okay, yeah, there might be a hair, but it's not a lot. 2.
Neutral.
Yeah,
Is that not elevation?
well, there probably is, but we need 2 full boxes. So right in here is where that thing starts to turn sideways. Somewhere in there it starts to turn sideways. Starts to go that way, maybe a little higher. Starts to go that way. But I don't think we have 2 full boxes. Close. V1, V3?
Pretty
Neutral.
Yeah, you might have a box, but you need 2 boxes, so it doesn't matter. V4? You definitely have a little bit there, right?
Yeah, 2 boxes.
2 boxes up there, but you don't have enough in V3. Do we agree? So does V4 matter?
No.
V5?
Yep.
Yeah, you got a box. Once again, a little bit of cupping. And then V6. Not enough in V6. Do we agree? Oh, well, maybe we don't.
It's hard to tell.
I'd say we don't when we look at this as the baseline back here instead of this. Look at that as the baseline. Gosh darn it. Can't even draw that from here. That's the baseline. When you look at that as the baseline, it's not great. Okay? What we end up having here is called benign early repole. Come on, Dane. Catch up to me. Oh, that's not. That's terrible. Paracarditis there. I went too far. Benign early repole. Okay? Because I had already brought it up, so I went to the next slide. We get this Ewing across, and then we're going to put it up here, STEMI mimic. You guys understand why this could be a STEMI mimic?
Don't take a close enough look.
That cupping can look like a STEMI, but all as it is, we get this J or fishhook appearance at the end of the J point, cupping, and you're going to see it across multiple leads. And it doesn't make sense for it to be in inferior leads and these lateral leads. And so you have to remember that that's probably benign early repole.
There's nothing inherently wrong.
Nothing. No, really doesn't matter that much. A coincidental finding on an EKG, meaning we don't give a damn.
I don't give a damn.
Will you put that like in a report? Your
No.
next part?
That's a good question. No, I'd be like, nah, that ain't.
No, not radio.
Oh, your report?
Like your actual.
Here's when I would do that. Let me clarify. When I would put it in my actual report would be when I'm trying to justify. If I thought QI or somebody was going to look at it and be like, that was a STEMI, you didn't miss it. I would make sure to put it in the patient appeared to have some benign early repole, and it does not appear to be a STEMI. In other words, I'm defending why I didn't activate a STEMI. Maybe you don't trust your QI team and you think you're better than them. I'm definitely going to write in there why I did what I did. Cool? On benign early repole. Does it matter? No, it doesn't matter. Does hypertrophy matter? Well, it could, but we're going to treat symptoms. Bundle branch blocks could matter. Could be a heart attack. We're going to look at that later more. Let's go to this next thing. There's benign early repole. Let's give it a slide. I guess this one's changed. It's different. Yeah, all right, cool. We'll pull this one up. He didn't have the fancy change slides on there, so it's hard for me to tell. All right, base rhythm. We have P waves. PR is equal to normal. Arch regular. All right, so we're in some sort of sinus rhythm. 300, 150, 170, 80, 90, somewhere. 90? So normal sinus rhythm. Yeah? Going to V1, is it wide or narrow? We all go with V1 being narrow? No bundle branch, cool. Looking at 1 in ADL. We have elevation, depression, or neutral. Look at across, I hear you, but look at across. Don't just look at the first beat, look at across the
I
way.
didn't know there's.
Why is the isometric line?
It's wandering, we have a bad baseline, could be due to some artifact. Somebody's not holding still, I don't know. Mad at the patient.
Both of them are.
Neutral, ABL's neutral, cool. 2, 3, ABF. Looking at 2 first, elevation, depression, or neutral. Elevation, we agree?
Yes.
1 box or more? Even though we have a crappy baseline, yes, we agree. 3. Neutral, good. ABF? The ABF isn't great, I agree, neutral. Going to V1. Box of elevation?
Yeah.
One you have
No.
No.
V1 is regular. You're on a neutral.
Now, I just want to make sure I'm seeing the same thing y'all are seeing. Because I'm seeing some elevation in V1.
But it's not on the first.
Yeah, it's only on the second, and then on top of that too, it's like.
No, it's okay, speak. So we're gonna look across the board. I think here the hard part is like, where is the J point occurring? Is it here, is it here? You know what I mean? So let's look across the board. Let's try to identify J points across the board and see. I think we might have a little bit of elevation there. We go to V2, do we have 2 or more boxes there? This is a very clear J point all of a sudden. Yeah, there's 3 boxes there. We go to V3, elevation there. So lead, lie,
Ass backwards.
SSA. So septal anterior, 5 and 6, LL, elevation,
Yes.
6. Yeah, I think we got a box there too. What kind of STEMI are you telling me we have?
Septal anterior lateral.
So septal, anterior, lateral. Can you have that? Yes.
So it's probably not one.
You can have that, but it might not be, right? What are we looking for? Well, pericard, remember that there was some elevation over there in 2, and you have elevation in laterals. Do we see elevation in 2 and elevation in laterals, inferior and lateral at the same time normally?
No.
No, they're reciprocal. We should not see them in the same direction, which means this is most likely a STEMI mimic.
You said
Yep, I can say that again.
lateral and inferior?
They should be going opposite directions. In this case, we see 2. We said, man, that looks like it had some in 2, right?
Yep.
And then we also have it down in 5 and 6. That doesn't match. That doesn't jive. It shouldn't be like that. Which means this is probably a mimic. And what we hear, it's pericarditis. Pericarditis, we see diffuse ST segment elevation across multiple leads, across multiple sides of the heart. Typically, they've had a recent cold, fever, illness. That's going to be how they present. I've been sick for a week. Now I'm having chest pain. You might be thinking pneumonia. If they have a respiratory, that could be true. Then you see this.
But
And it's
their
pericarditis.
troponins elevated above well, since it has a non-STEMI.
Right, probably.
That's
Pericarditis.
exactly what happens.
So if you see elevation across multiple leads, it is most likely across lots of leads, including leads that don't make sense. And if they have any history of illness or infection, it's probably pericarditis. Oh yeah, it's not on the board yet. And number 4 is pericarditis. Of course they don't have, what is this?
We're trying to like find things that could mimic a STEMI if we're trying to rule out a STEMI, but these are legit. Some of these are legit problems that they could have that we would just be finding, right?
We're finding it, we're also saying, hey, that has chest pain, but it's not necessarily STEMI. Even though it looks like it could. So we're doing 2 things. STEMI mimic, not necessarily a pre-hospital emergency, but an issue. Or maybe that we're going to treat part of it. Let's do this one. Do we have P waves?
Yes. Kind of.
Yes. I think so. I'd like to see those. Okay, here we go. 2 has them too. So look at me. I'm looking at multiple leads here. Say, do we have P waves? It's junky though. And then we look at V1. So we're saying there's some sort of sinus rhythm in the background. We look at V1 and we say, look at that wide, ugly, nasty rhythm. We check our Q restoration. It's 0.128, which is greater than 0.12, which means it is a
Baby bundle branch.
it's a bundle branch. It is a bundle branch because it's greater than 0.12, and it has P waves. Okay. Bundle branch. Now we say, is that more up or more down? More up, which means it's a right. Everybody's good with that. Nobody's struggling with right versus left. It's okay. I'm baselining this, making sure we're good. So we have a right bundle branch. Okay. That hits our STEMI mimic list right there. We can go ahead and walk through the rest of it, but I'm telling you there's not a lot of purpose in saying where's our elevation, do we have elevation here, there, and whatnot, because we're in a bundle branch. There's a criteria to kind of rule in a bundle branch from a STEMI and rule out a bundle branch from a STEMI. We're not covering that yet, but it's called scarbosis. I will never expect you to memorize scarbosis. I would expect you to utilize it as a resource. I'm on the way to the hospital. This patient looks like junk. We know it's a bundle branch. I'm not getting too worked up, but we're going to the cardiac center. Now I get out that criteria and say, could this be a STEMI or is it most likely not a STEMI? That's when we would go to scarbosis, but we're not there yet. This is some bullshit, but I don't want you to even try to remember, okay? You can sometimes see cardiac changes in something like a pulmonary embolism. But you're never gonna remember that. Whatever that says, new right bundle, do you know if it's new? Nope. We aren't God. S1Q3 T3 pattern. You're never gonna remember this. So don't trip up on this. That's baloney doctor stuff. When we get people that are super cold hypothermia, they call this a J wave. I don't like the extra letters, but you get an extra little pump there on the backside of the QRS before the T wave. You may get T wave inversion. Really just means you better be careful with that really cold person. Really, really cold people can go into cardiac arrest. Say that again?
Probably not, is that malignant hypothermia?
You're talking about malignant hyperthermia.
Oh, okay.
We can give people succinylcholine, and sometimes it can put them into this malignant hyperthermia, and that can be bad too. Good question. Don't trip on that being an Osborne or J-wave. Just know that that extra little beat goes along with hypothermia, being too cold. You'll see that in any lead, yes. Whoever asked that, yeah. Hyperkalemia, I believe that's one of our semi-mimics too. And then it should be so hyper K. And then pace rhythms is our last. We've already kind of covered pace rhythms, so I'm not going to go back and recover it.
But then this goes into, that's why I was asking on these if they matter, because hyperkalemia does matter, because that's a.
I'm not saying they don't matter. I'm saying they're not STEMIs. And we still have to treat our patient. Is our patient, so when you get to this board, what I need you to know on STEMI mix is what is your patient doing? Sick or not sick patient? Sick patient with a bundle branch block, we're treating that seriously. We're going to a cardiac center. And it's not necessarily this that's the issue, but they're a sick patient. Sick patient with hypertrophy, that's a cardiac issue, needs to go to the cardiac center, not a STEMI, still treating the underlying. We can't fix hypertrophy. We can fix maybe the underlying symptomology, being hypotensive, not having enough fluids, needing a pressor, things that we might have to do here. Benign early repulse, doesn't matter. Pericarditis, sick patient, needs antibiotics. You may or may not be able to start that treatment based on the patient in your department. Hyperkalemia, sick patient, needs fluids and maybe dialysis, depending on the causation. We can give fluids, we can't give dialysis, but we can take them to a hospital that can. Paced rhythms, now that might be normal. What else is going on with them? Okay. So I wasn't saying just ignore it. I'm saying it means it probably isn't a STEMI. If you see this and you see what looks like a STEMI, you're going to rely on it. It's probably not a STEMI. Unless we do scarbosis and roll it in the house. Hyperkalemia, we get these massively tall peak T waves. It hits the STEMI mimic list because we see these tall peak T waves in multiple leads, and it can look like elevation, but you see these pointed mountaintop peak T waves. Typically, it's hyperkalemia. Too much potassium. Hypokalemia, we just get flat T waves. Too much calcium is called hypercalcemia, and we get a short QT. The amount of calcium regulates how fast that sodium, potassium, calcium pump happens. So if we get too much calcium, it speeds up how quickly we repolarize. Does that make sense? Go back to sodium, potassium pump. Remember Na and Ca and potassium? If there's a lot of this, it's going to rush in there faster, and it's going to speed up how quickly the cell depolarizes. Does it matter to us? The short one, not so much. Too little calcium, long QT, and you give a QT prolonging drug, that'll matter. So they already have a long QT, a QTC over greater than 0.46 roughly. There's a difference for males and females, but I always just say 0.46, it's easier. And then you give Zofran, and they've already taken Advair or whatever, another drug, you can put them in that are on T, emotional cortis, which is a bad deal. Is this anything? Hypertrophy, this is cardiomyopathy, hypertrophic. It's still hypertrophic, okay? Dilated, weakened muscles and its ability to pump blood, heart enlarged and stretches. Hypertrophic, the walls thicken. So those go together most of the time. When we talk about cardiomyopathy, that's the dilated, weakened muscle. Hypertrophic is that muscle wall being thick. And it looks just like this. See how those R's and S's are all running into each other? This becomes very hard to determine what the hell you're dealing with because it's all running into each other. And it's very frustrating as a medic when you're like, I can't even see what I see. Like
Sorry.
no, you're good.
How do you determine if it's right or left?
I don't want you to key up on
Okay.
it, especially not now. I don't know that it matters to us. Ever. I had to think about it before I said it, but I also know I'm being recorded. We're putting things on YouTube and I'm like,
Recognize that.
hypertrophy, and that it's most likely not a STEMI. Okay. And once again, do you even see any ST segment elevation here? Let's look at V1. Now, for some reason, they have V1 at the bottom instead of your normal 2 or 3. That's a little annoying, but that's just what they have selected. So there we see V1. We have P waves. Yeah, they're not great, but they're before those QRSs. We have QRSs and T waves. We have equal R to Rs. We're slow, right? How slow are we? That says 54 up top. So we're in a sinus brady, we agree? That says junctional rhythm. Do you see that? The dog in the box says junctional rhythm. It means it's missing, and that's possible to do, that right there. There's little bumps there. I can see them. They're not great, but they're what I would call clear and identifiable. That one's real clear. Here's the other thing you can do. Look across the board. I see why it's saying junctional, and now I get it. Once again, we're in V1. It looks different. Inverted P waves. That's what it's picking up right there and there. When we look at 1, we don't really see anything. So it's a good example of looking across the board. We look just here and we think, well, that looks pretty normal. We start looking at our normal leads and we're like, oh, those are all inverted P waves, right? So yeah, that's a good example of looking across the board. That's why it says junctional. And it's right. Once again, doc in the box says something, figure out why it says it. Why is it tripping up on that? Well, it was right. So we got junctional underlying rhythm, okay? 1 at ABL, nothing. 2, 3 ABF, nothing, right? Everybody good with that? Maybe 3 has a box, but 2 and ABF don't. Yeah, V1 has some elevation, but does V2 have any? Nope, it doesn't. V3 doesn't have any, V4 doesn't have any, V5. So it has inverted T waves. It doesn't look great. Those R to R's running into each other, but it's just another rhythm, okay? We already looked at that one earlier. Brugada is this concept. I don't like Brugada that is even on here necessarily. You see a STEMI with Brugada, that's what you see, and then it goes back to normal before you get to the hospital. Okay? And it's due to, it's a 1 in a million kind of deal. There's no cure. They can have syncope, seizures, difficulty breathing, shortness of breath. Normally undiagnosed until we take them to the hospital a few times. They keep getting better. They need medications. Yeah. Just here's what I need to tell you about Brugada. It's a thing. So if you see the word Brugada on a test, it's a thing. Treat it just like a STEMI. And then the doctors can tell you you're stupid later.
But that's not considered a STEMI.
I wouldn't even put it up there because I can't tell the difference. I cannot tell the difference in this in the field versus it being a STEMI. So I'm going to treat it like a STEMI. I'm going to activate a STEMI, and then if it goes back to normal, the doctor later can be like, "Oh, that one's Brugada." Okay. Are you two okay? You look like you're struggling.
I just, well, I'm like, I understand why, but I'm confused of, like, where we start, like, I get we start with V1. But then after that, I'm kind of lost in the
Okay.
order.
So we always go in order, but by order of location. Lateral, lateral. The 1 and ABL, we look at those 2 together because they're a pair. Then we look at 1, check it. Then we look at ABL, check it. Then we go 2, 3, and ABF together as a team. So is 2 got it? Yes, no. 3 got it? Yes, no. ABF got it? Yes, no. Then we've decided whether or not we've got any inferior stuff. Then we go V1, V2. So I just go in order by pairs. That one's 3, but the rest are pairs. Then V3, V4, V5, V6. Lead lie ass backwards all. Just going in order. L's, I's, S's, A's, L's again. It's a good question. Don't ask the questions because I guarantee there's other people that are like,
Because I'm going through it and I'm just like,
yeah, don't go in order. If you go 1, 2, 3,
right.
you're fucking up. I'll have Andrew put a warning on the pull request.
So lateral, you have 4 lateral views.
4 lateral leads. Yep. Emily?
That L.
Lee,
L.
L-I-I,
I.
lie, S-S-A-A-L-L. Did that answer your question or did I just say? So S's, A's, L's again.
So if you gotta have it in 2 leads, can you have elevation in 1 and V5? And that be considered a STEMI, or is it only those pairs on opposite sides?
Yeah, I'm gonna say no to that. V5 and V6 are a pair. V6 and 1 can overlap. But I would not be looking at AVL and V5 or V5 and 1.
It's kind of a different lateral.
Yeah, yep. Generally though, if you have this and this, you also have that and that. You can have all 4 lateral leads popping. That's the whole circumflex is blocked up basically. That ain't good. And I bet if you get to the whole circumflex backing up, at some point you're gonna start to see some anterior as well. It'll start to kind of bleed over that ischemia.
So left anterior descending goes top left. The right anterior descending obviously.
No such thing as right anterior descent. Right coronary artery.
Right coronary artery. goes-
Why would it be the same?
Yeah, but it. is
And it starts off as, to be clear, it starts off as left coronary artery, goes to LAD. So that's partially why.
And then where does the circumflex start and where does it integrate?
High up on the left LAD, and it kind of curves to that lateral wall.
And covers the left back.
Yeah. All right. That's just QT right there that it's measuring. We're going to keep moving. Try to get through some of these 100 slides-ish. But that's just the QTC that it's measuring. Remember that seating 0.44 they use here. 0.45 is kind of a good number. It's a little different in women and men. So it's 0.44 and yeah, I'd have to look it up. I kind of go with 0.45 as a general rule. If it's longer than that, I'm going to use caution with things like Zofran, knowing that I don't always get a 12 lead, but I try to most of the time before I get something like that. This is another one of those zebra things that you're never actually going to remember. And I don't expect you to, but hey, you got a stroke patient and they, you're not sure if it's a bleed or not. And you look at their pupils and one's probably deviated off way one side. I'm not going to go ahead and check the 12 lead for this because I'm too busy taking care of my patient who, when they have a brain bleed, has normally shot themselves and is not breathing. Okay. Like when they're hemorrhagic stroking, there's a lot to do for a paramedic. And it's not like, let me check the 12 lead for this weird, obscure thing. Some of my students get really drawn in on this stuff. They try to get really into, symmetric T waves with prolonged QTs, blah, blah, blah. No, I'm just going to go with the fact that they are barely breathing, have poo everywhere, and their pupils off to over here, just blowing out their mouth. Okay, so don't key in on this, okay? Pay attention to your patient. All right, now we've gone through a lot of slides. I'm going to run through a lot of rhythms. I'm going to run through some slides here about stuff that we may already know. And then we're going to get through that and probably call it that. But yeah, we got 100 slides to go, so give me some. Anyway, coronary vascular disease, CVD, okay? Angina, AMI, heart failure, hypertension, stroke, all coronary vascular disease. I hate the acronyms, but they're there. We know ischemia is oxygen deprivation, infarction is tissue death. So the good thing about these slides is it's stuff we probably kind of understand a little bit. Yeah. So we can move through the, hey, words. Atherosclerosis, that's that plaque inside the lining of the blood vessels starting to narrow. Could cause arterial sclerosis. There are modifiable risk factors and non-modifiable risk factors. Non-modifiable, genetics, things you're born with. Modifiable is things you can take care of, like your diet and your blood sugar and your blood pressure, those kind of things. Angina is pain, right? It's a primary symptom of coronary artery disease. If it occurs at rest, it's more severe. So we have stable angina. Stable angina can be treated with nitro and rest, and it goes away. Unstable angina, pain at rest normally, that's not treated well or not going away with nitro. Unstable angina often means we have a heart attack coming or it's already there. There's kind of the breakdown. There's a very good chance you'll get a test question. And I think I talked about this the other day. Old man goes for a walk to the post office. Well, they're going to say, 72-year-old male goes for a stroll to the post office, lots of words in there that don't matter. Okay, on the way, he starts to have crushing chest pain, takes the nitro, and is unrelieved. Blood pressure is 140/90, heart rate's 120, oxygen's 92%, respiration's 22. Is the patient having unstable angina, stable angina, a STEMI or we'll just say non-STEMI. We'll make all four of them possibly right answers.
Unstable angina, because you don't know it's a STEMI yet.
Yeah, we don't have 12 leads, so we don't know it's a STEMI. Could be having STEMI, but the most right answer is unstable angina. Could he be having a STEMI? Yes, we need a 12 lead for that. Unstable angina because
it did treatment.
didn't get better with nitro or rest. Okay, we know he has a history of because he has nitro in his pocket. This is stuff that you're digging into on these test questions that pisses you off. It may then say, Josh, what are you doing next?
What am I doing?
And then the options are 12 lead, aspirin, nitro, or an IV. Not an option for some reason.
We're gonna.
That's a good point though. If oxygen was an answer, do you give oxygen? Airway, breathing, circulation, yes you do.
I would do a 12. That's your number. You said 12 lead IV,
Aspirin or nitro?
aspirin or nitro.
Oh.
If there's any contraindications,
One for you, man.
I would probably do.
We'll do some aspects.
I would do
Aspirin.
aspirin because it's super quick and then you can worry about.
Aspirin, 12 lead, and you might be like, but Nick, that's subjective. It is a little bit. Here's the thing though, can you do aspirin and 12 lead at the same time?
Yeah.
Yes, which one helps the patient in theory? The aspirin does. Is the aspirin gonna change to 12 lead? Unlike nitro, the answer is no. I'm telling you, it gets that sticky on these questions. And you're like, that's not fair. I get it. I'm gonna go take National Registry, the exam for my research, not because I want to, I vow to never take that test again. I'm only doing it for you people. And if I fail, we have a bigger problem, A, and B, I'm gonna research with my CEUs. So I will be okay. I'm gonna make Andrew take it too, because he's also up, and Jared, I think one of them's up this year, one of them's up.
We're all gonna take it. Tell us who gets the hot.
They don't tell us. I don't think they'll even know. They only tell you the score if you fail.
Oh.
They only tell you your number if you fail. Otherwise, it's just a pass, and a doctor's a doctor. The worst doctor you know, we don't know their score. They're still a doctor, like vice versa. Best doctor you know might have had a terrible score in school. All right, let's keep moving. Variant angina. Oh, this is tricky. There's this thing. I'm going to hit this really quick. Coronary artery vasospasm. I've had this once at a time. Not myself. One of my patients. A lot of times it's with drugs. They took a bunch of drugs. They spasm down, so all of their arteries crunch down. They show like they're having a STEMI. It looks like a STEMI. It talks like a STEMI. We activate the STEMI. We get there, and they do the cath, and there's no blockages, but everything's shrunk down, and they have to give them a bunch of drugs. Nitro might work. Sometimes it works with nitro. We're like, cool, we fixed the problem. And sometimes they need other drugs to get them to stop spasm. Okay? Is what it is. Keep going. Microvascular angina. That's just a small artery constricted. So we're not going to worry about that. Acute myocardial infarction, that's the big name for a heart attack, right? Deprivation of blood flow long enough for portions of the cardiac muscle to die. You need to know that word, okay? Infarcted tissue is surrounded by a ream of ischemic tissue. That ischemic tissue, lack of oxygen, is electrically unstable, meaning the electricity tries to go around it, and we get the electrical changes. Okay? We do the STEMI thing, we identify, we notify, we transport. We do all our stuff. STEMI's time sensitive, so we're gonna probably be moving with some speed within protocol, lights and signs carefully. Different symptoms, we already talked about this. Women present differently. Sometimes you get toe pain in women. Women of cardiac age with pain should get a 12 lead. Cardiac age is subjective. It used to be 35 and older. Now, just do 12 leads. I don't know. It's good. Not every coronary syndrome patient has a chest discomfort. So the silent MI. That's my mom. She woke up. She's 59 years old at the time of her heart attack. She wakes up that morning. She just feels stiff in her back. Stiffness. She has a back stiffness every day. She has arthritis. She thought it was fairly normal. And she doesn't want to eat breakfast because she's nauseous. Okay? Nauseous, back pain. Apparently, at some point in my time, I told her, and I don't remember it at all, but I'll take credit. I told her that if she started having arm pain or jaw pain, call 911 right away. She starts having left arm pressure, or pain rather, and some jaw pain, and that chest pressure is occurring. All of a sudden, she tells my dad, who's the most stubborn man in the world, that she needs to call 911, and he actually does it, which I'm still shocked of today. So they call 911, St. Charles County Ambulance District comes out there, one of the best ambulance districts in the state of Missouri. Very well known.
That's St. Louis?
Outside of St. Louis.
Yeah, they just got a ton of awards for something.
They're pretty good. So they come out there, they look at mom, they're like, man, I don't see a STEMI, but get in, we're gonna take you to the hospital. They send the 12 lead all the way to the hospital. Who can send 12 leads?
Some hospitals can't.
Some can, some can't, right? Okay, so they send the 12 lead, the doctor at the hospital says, hey, that looks like a STEMI. You know, go faster, get here, we're activating a STEMI team. They get mom in, they take her into the cath lab. She has 100% occlusion of her coronary artery and another artery, the ramus intermedius that comes off of that to the back, okay? They have a hard time stenting it because it makes such a sharp turn off the LAD. It's a very hard swing to get into one of those. Anyway, they get it out. She gets stented, she comes out of surgery. The next day she's visiting with a cardiac surgeon, and they're surprised because her ejection fraction, the amount of blood ejected out of her heart, is back to almost normal. And most people with post-surgery, post-heart attack have decreased ejection fraction. Sometimes they never fully recover. There's too much damage to the heart.
So your mom's like that.
But she's just better. She's all of a sudden better. No risk factors other than high cholesterol going in, high triglycerides, high cholesterol. She eats healthy. She knew she had high cholesterol. She took medicine for high cholesterol. She ate fish and all the right things to try to address that. Not a drinker, not a smoker, none of that other stuff, okay? Tried to walk and do all the healthy things. So she's an anomaly. The doctor draws her heart, shows her the blockage, all hand drawn, which I think is kind of crazy but cool. I have a picture of it somewhere. And he writes in there, oh, come on, brain. It's the fancy word for broken heart syndrome, which,
Where your chordate tendon is, right?
no,
Have you ever heard of that?
I wish that my brain could work. No. I mean, I have probably, but I don't know what you're talking about. I want to tell you the word, but I can't think of it. Anyway, it's a big word, yes. Say it, let me see it, because I know what you're trying to say, but I can't. Takasubos. Takasubos, what's the last one? Yeah, okay, good. Takasubos, so you wrote Takasubos in there, question mark. And the reason they put that in there, she is a stressor. That is actually her risk factor. She stresses about everything. So I'm assuming she was just sitting and stewing all night long, whether she was awake or not. And she had this heart attack. It's a real heart attack. There was plaque in there. They found plenty of plaque in there, but she had plaque plus the stress. She gets that spasm. And then they go in, they stent it, and it all goes back to normal and everything's fine. So that's the good thing for her. She's okay. She still has several small blockages, but in the United States, if your blockages aren't over a certain percentage, like 90%, our healthcare system says we'll just leave those ticking time bombs for like, all right. So it really pissed me off because like there's some 75 and 70% occlusions. And I'm like, she's 59 years old. The math to get to 70% occluded over 59 years tells me that if she's pretty healthy. Her mom lived to this year. Her dad lived to this year. She's on a time frame that she's going to live to those years anyway.
Yeah, but if she hasn't lived over and died yet, we're not.
Right, they didn't care. So I'm like, oh, that's good. Now they took her off the blood thinners because that's safe. So anyway, yeah, doing lots of 12 leads. We're getting lots of histories. We're putting all that information together to figure out what we got. Okay. Treat your patient, not the monitor. Treat your patient, not the monitor. The monitor can look really bad. Your patient can be fine. The monitor can look fine. The patient can look really bad. Treat the patient, not necessarily the monitor. What if you have a STEMI on the monitor? Your patient's, I don't even have chest pain.
And you
They're
just,
on the side
you
of
kill the
couch.
guy, because we're like, dude, you're having a STEMI, it's like, don't do anything. He ended up flying, and if he did.
I thought you just like, okay, so it's the same thing, you
I
just.
would err on
drive
the opposite
side.
side. Well, it was way out, and it was down south of ours.
So first thing I would say is check your lead. Check your lead. Are they in the right spot? Check your leads. That's the first thing.
We bring 312 leads, and all of them are like.
Second, after that, take a deep breath and start taking your patients to the cardiac center. You don't have to freak out. Just start getting to the cardiac center. And then if they get worse, because you're going to do continual trending 12 leads. If you start to see it get worse, upgrade. How long do you cardiac So, yeah, I was gonna say sick or not sick. So if I don't suspect MI and I'm just doing a 12 lead and I'm going on a long transport, once at the beginning, once at the end, if I'm gonna do it, you know, if I'm suspecting MI, 5-10 minutes, like I'll do them like crazy if I'm really worried. If he's sick, they're sick, I will run those 12 leads. I'll print those. I'll waste all the paper. I don't care. Yeah.
Tyrese has a question.
Tyreek, sorry, bud.
So with his.
I have no idea what happened.
So like, would you tell?
I would not have flown that dude.
No, I know, but like, would you, because if he's not.
Unless he looks sick. If he looks sick,
No, he was like, he was.
why did you call 911?
It felt like mild indigestion.
Oh, see, I would have flown that dude. Never mind.
And then when we
So
got
the
there-
story matters so much. You guys ever seen that? Because he just went from, oh, he had nothing wrong with him. He had nothing wrong with him to he felt some burning, indigestion, didn't feel right. And then we get him on the monitor. That paired with we get him on the monitor and it's screaming steady. And you're like, oh, bro, you just don't know how bad this is yet. Yeah, I would absolutely, yes.
Well, because he said when I called him, and he went away. And we hooked up after he was saying.
Man, a shitty medic would be like, all right, well, you don't need it.
Yeah, we'll see ya.
Push
Yeah,
hard, don't stop.
what did you eat last night? You had some spicy food, we're out. Sucks. Because you're gonna get called back 2 hours later with the wife screaming at you because he's dead. And the lawsuit will hit on Monday morning. But he signed the refusal. Can you get sued if you sign the refusal?
Yes.
Yes, you can. Yes, you can. You can get sued no matter what. How it goes in court, that all depends on how good your lawyer is. That's a whole
And
different
how
story.
good your report is.
How good your report is, how good the lawyer is. Did you write in your report? Because I write this in my report. Inform the patient the dangers of refusing up to and including death.
Patient
That stands up pretty well. I told them the risk up to and including death. The patient was alert and oriented times for the life, witnessed it. She was present and signed with me.
So do you as often as possible try and get a witness signature on refusals?
We have to. Short subject, we stopped doing that as a matter of practice. We used to do it every single time. So
Personally.
I think it's a good idea. We stopped doing it as a matter of practice.
Alright.
Because our billing company no longer requires.
That's a question, that's kind of fine, ask it, but I was gonna ask, so in this situation,
Sorry,
how do
I cut
you,
you off.
how do you inform the patient? Because like, I'm assuming stress is gonna make that worse. How do
Oh,
you
good question.
inform the patient without?
Listen, dude, I really see something on here and I really think you should go get checked out.
So Mr. Smith, we're seeing, based on your symptoms, that indigestion, what we're seeing on this cardiac monitor, it looks like you are having a heart attack. Now, you're in great hands. We're gonna take good care of you. I think our best option, if you're okay with it, since we are 4 hours from a cardiac center, 3 hours from a cardiac center, we're gonna go ahead and get the helicopter here. They'll be here in 20 minutes. They're even better than we are. We're gonna have great care the whole time. We're gonna keep you as calm as possible. We're gonna put some oxygen on you, just try to keep your heart chill, or we're gonna get you going to the hospital. If they freak out after that, you just deal with the consequences. But most of the time when I touch people like that, I think you are having a heart attack. We're gonna take good care of you. You're in great hands. We got now. You better, for that to hold up, you better act like you know what you're doing. If you're like, Mr. Smith, I think you're having a heart attack today, and I'm gonna do my best to take good care of you. Like if you're freaking out, they're gonna know it. And now what's gonna happen to Mr. Smith's stress?
They're freaking out.
So you can freak out inside, guys. How do you not freak out outside? Take a deep breath. If inside you're shitting kittens, before you talk to Mr. Smith, maybe two. Hey, Mr. Smith, you're having a heart attack, and I'm here to take care of you. It's gonna be fine. Inside, you're like, no, I don't know what to do next. Levi aspect was all.
My family has the worst history. He references them all the time.
Yeah, you guys are always sick. I don't know what it is.
Smiths, I guess.
The Smiths. Anyway, all right. Aspirin and oxygen. Okay, aspirin and oxygen. That's our first thing. 12 lead. Within 10 minutes of patient contact, preferably as soon as it's available. We've already ran through that one. Okay. Do we need to should we run through it again for practice?
Yeah, sure.
Let's do it. Do we have P waves?
Yes.
P waves. Are regular? QRS narrow. Our is actually not regular. It gets wide. It slows down. So we are actually in a sinus arrhythmia. It looks like we had a rate change. I don't know why. We are. Okay. Going to V1, wide or narrow? Narrow, so no bundle branch. Yes, good. Okay. Looking at 1 and AVL at the 1 first, then AVL. Neutral, depression, elevation. Depression in 1. AVL. Depression. 2. Elevation in 2. 3.
Elevation.
Elevation. AVF.
Elevation.
Right now, we think we have what? Inferior STEMI. You can't just tell me STEMI. You got something where? So inferior STEMI. Okay, because we have elevation with depression. Is that a thought like you're going to say something, or are you just good? Okay. Elevation. We're looking at an inferior. Which contiguous. Yeah, you missed part. You're all right. Too contiguous. I am going to post this on YouTube, so you guys, if we cancel tomorrow, you can still watch it.
Like and subscribe.
Yeah, I mean, I'm gonna try to monetize. Kidding. V1, V2. Maybe 1 and V1, but we got nothing in V2. So if we have 1 and V1 and nothing in V2, what does that mean? Means nothing. V3.
I think elevation back.
Maybe one box.
We have 1 box. Can't look at that one. Remember, sometimes these are the old, like just here. There's a box. Box. Not enough. V4.
I don't know.
Nothing really at the J point. V5 and V6. Nothing. So we have an inferior STEMI. We got to glance at our STEMI mimics. We don't have a bundle branch. I don't see hypertrophy, which is those massive R waves running into each other. I don't see benign early repole where we have that U wave, not U wave, that cupping coming out of the QRS into the T wave. Pericarditis, we don't have across the board elevation, right? No. Hyperkalemia, massive peaked mountaintop T waves. Negative. And that would again be mostly across the board. Paced rhythm? No. So we have a home run STEMI. Inferior STEMI. Now, if it's an inferior, before we give nitro, we're going to check blood pressure and then, yes, and then what else are we going to check? The right side. We're going to check the right side for right side involvement because a standard inferior, we're going to see a 10 to 20 point drop, no big deal. And that's kind of normal. Like a normal drop in blood pressure on a STEMI, 10 to 20 points, not a big deal. So we can go, I don't go as low as 100. My personal rule is 110 systolic. I'll give a nitro 110 or above. If it drops below that, I'm going to hold off because I don't want to go down to 80. That makes sense?
So you're always gonna check the right side if there's a student.
If you have inferior, you check the right side. If you don't have inferior, you don't have to check the right side.
When you hear it as inferior wall of like, you hear kind of.
No, you say inferior. We don't say inferior wall, just inferior. So we check the right side. Right. So why do we check the right side? We can have a 40 point systolic drop on right side of STEMIs. So we make sure we're clear on that. That's, if you have right side involvement, you can drop by 40 points.
That's the test question.
It's a real life thing.
So
It's not on the test.
So
That's a real lifer. In fact, the test
V4R.
doesn't tell you, real quick, the test doesn't tell you shit about when to do right-sided. It doesn't tell you shit about when to give nitro on right-sided, when not to give nitro on right-sided. It's like all your local protocols. I bet none of your local protocols address a right-sided center. They'll either say, don't give nitro in inferiors, which is asinine, or it will say, most of them will say nothing about it.
So
But you gotta know, because you'll kill somebody.
if you have an inferior STEMI with a blood pressure of 160.
Sure. I would still check the right side so I know what to tell the doctor.
Yeah, I know, but I'm saying.
Yes,
You check
yes,
it and
yes.
it's 140.
Let's say right-sided no involvement, we're 140 over 80. I'm gonna give nitro with that IV line and fluid rate.
I'm saying that right side STEMI, do not give that.
Hey, that's where Harrisonville must be. Nice. Good stuff. Check the protocols.
Now you make.
But you just said it was bad.
I bet most protocols don't say anything about a right side. What does it say? Don't give it at all.
If right side is stimulated, you're gonna give nitro and fluid both.
So it really is gonna, I mean, they shouldn't just say that. They should say.
should have a blood pressure.
They should say, there should be some sort of cutoff. The reason they say it like that is they assume, and they're gonna be right most of the time, that when you have a right-sided, your blood pressure is gonna be intolerable or nitro. That's true most of the time, but we don't like always and never. So I'd rather have a number in there that says, hey, even if they said 150 systolic over 90 or whatever, like that gives you some play in case you have that weird patient. All right.
So it says contraindicated in patients with inferior stimulus.
That's wrong. That's boo.
Unless hypertensive emergency diastolic blood pressure greater than 130 associated with chest pain or CPAP.
Boo. Boo. Is that Lee Summit? Oh.
If CJ.
Oh, sorry. We're on. Never mind.
Hey, I'm gonna send that to Chief Dork.
Ours says,
No, don't do that. We want to support them. Maybe we can have a conversation.
ours says, you have inferior high, consider well-sided,
Good.
elevation noted in severe for nitro and or opioids may cause hypertension requiring fluid.
So still do it.
That was
Still
not-
do it. It's like-
All right, that's what it's saying. All right, let's keep going. We'll talk more about that another time. We got semis, we got non-semis, and then we got normal. We gotta go to the STEMI center. The ACLS is gonna ask you some door to window and door to balloon times. Door to window and door to balloon times, okay? What does that mean? It means from the time you roll the patient through that door to the time they start cath, I believe it's supposed to be 45 minutes. And it's 60 minutes to the time they get the balloon done. And it's supposed to be 90 minutes from first medical contact. And I'm telling you, those are ACLS test questions. Some variation of what I just said. 45 minutes door to intervention start, 60 minutes the door to balloon, and 90 minutes from first medical contact, meaning us, to the time they get the balloon done. Here's why St. Luke's East hates JCAT. Right here. It takes us 45 minutes to get to St. Luke's East, at least.
So you mess up their stats.
We've screwed their times. This is why Lee Summit probably is neutral, but they like when we call ahead. So a lot of times we tell our staff, as soon as you see the STEMI, get on the horn, even though you're 45 minutes out, don't give them any patient information, and then, hey, we got a 60-year-old male with STEMI, we'll be there in 45 minutes. So they can get their team ready. Because we have screwed most of their window right off the bat of the 90 minutes. But if we can pre-alert them appropriately, they can catch up. So if they trust us, if we blow the trust on activating non-STEMIs, then they don't activate. And now the patient that we take in that they didn't activate on, their time suck.
A door to balloon is 60, you said?
Door to balloon 60, 45 minutes of door to intervention, which is door to needle. That's what they call it, door to needle, 45. Door to balloon is 60. First medical contact of balloon is 90.
So Lee Summit is a level 2.
Yeah.
For
They can do that, yeah.
STEMI and
Period.
trauma?
No, they took away trauma designations for outer hospitals within so many miles of other hospitals.
So level 2 means you don't have staffing 24/7, but they're on call.
Yeah, basically, they can do certain interventions. So like Lee Summit shares their team with OPR. So that team travels back and forth, the on-call. Now, during the day, they may have their own team, I don't know. But the on-call team for after hours, weekends, is traveling back and forth based on need.
Okay, so what if
OPR has one on the table, I've had it happen. You should get diverted. But what does it?
OPR or 2 reasons?
To another facility, research St. Luke's, who cares? I've had it happen where they didn't divert me because they didn't necessarily take the trust. We get them in there. Now they're critical. And now the team's busy, and now they're stat transferring Lisa and Fire out.
Oh, really?
I bet you.
Lisa and Fire also doesn't love how many transfers they have to take out.
He's in charge of.
Dude,
all.
but you gotta stop shooting me.
I'm not blaming you, my friend.
Alright,
No, I'm just kidding. Every place has to deal with transfers. Unless you don't. Alright, let's keep going. We talked about semis, we're talking about, the whole process. Ideally, our dispatchers are recognizing things, giving pre-arrival instructions. We do a good job. When the system works together, we do a good job. We get an early 12 lead, we get early aspirin, we get early nitro if possible. We pre-alert our hospital, let them know we're coming with a good ETA, like as far out as possible so they can start their processes, especially on nights and weekends. And then we take them to their appropriate hospital. The crews there, the staff there do a good job. that get them to the cath table fast and appropriately, and this patient's gonna walk out of the hospital and be fine, okay? We just talked about EMS the balloon, door to needle. Nitro, we talked about if nitro doesn't work, you can repeat that. Most of your protocols say up to 3 times. A lot of them will say you can give it once. If it doesn't work, stop using it. That's kind of local protocol. You can also go to, it looks like I'm gonna keep using that. As long as their blood pressure tolerance. You can also go to some fentanyl to help with pain. If they're in a lot of pain, they're not gonna do well. We gotta we gotta calm them down, we gotta help the pain, we gotta take off stress. So nitro's opening it, so we get some blood flow. If you're having a STEMI and they're in pain, even if the nitro doesn't work, I'm gonna keep giving that for this reason. As long as their blood pressure is appropriate. I'm trying to get some blood flow through. But I'm also going to give the fentanyl for pain management. Yeah, high risk refusals. We talked about that. High risk refusals. They're dangerous. Try not to get yourself. Don't work refusals. Work transports. Our job is to take people to the hospital. You may not like this. We take people to the hospital. I can actually, most of the time, get them to the hospital and be done faster than I can jacking with a refusal business. Where it takes a long time. You got to talk to them and talk to them. Like, let's go to the hospital. Let's get people to the hospital. We get paid for it. We knock it out. We don't have to come back 5 minutes later. We don't have to come back for a heart attack later or a death. Let's get people to the hospital. Heart failure occurs when that heart can't pump fast enough to powerfully enough to empty its chambers. We talked about left-sided versus right-sided, right? Left side, our strong side, pushes out to the whole vascular system. When it fails, it backs up to where? Left side, lungs. Backs up to the lungs. When the right side fails, it backs up to nothing. Body and feet. Okay. Cause of heart failure, normally we're talking about coronary artery disease or hypertension. Here's some other causes up there. Contributing factors, thyroid, alcohol, cancer treatments, yeah. Symptom onset, is this acute heart failure? Is this happening right now? Are they in immediate crisis, been ongoing for a long time? Is it chronic? Is it left-sided versus right? We already just talked about that. It's going to be affected by any condition that affects preload, afterload, contractility, or heart rate. So if they're in heart failure and then they have a heart rate problem due to something else, that's going to be an issue. Be a big issue. We just talked about this. This is just all the words we just talked about. Blood backing up. We had that right ventricle has to overcome systemic resistance, blood pressure. Lots of words on the screens that we've already talked about. Cor pulmonalis is one of those fancy words they throw on tests to try to get you to pick it. I'm not saying it's never the right answer. I'm saying you got to know. This is right ventricular failure that generally is caused by the pulmonary disease of COPD. What you probably need to know is right ventricular failure coupled with COPD is cor pulmonale. Big word, they're going to throw on a test. Most likely not the right answer. Most likely it's a distractor. They're going to see if you go for it.
What did you say?
Cor pulmonale, right ventricular failure coupled with COPD. That's just the terminology. It gives me a better explanation. So you get pulmonary hypertension, the pulmonary arteries, right ventricle must work a little harder to overcome increased resistance to eject blood. Right ventricle enlarges, and left eventually fails. The pulmonary disease caused by COPD.
So pulmonary hypertension, can you explain that really quick?
Yeah. So, okay, I have to think about this, but yes, I can. What's happening in COPD?
COPD, you have emphysema, bronchitis, which causes.
Talk to me about the alveolar level. What happens?
Alveoli will break down, so you have less surface area.
Less surface area, less area to exchange gases. Less area to exchange gases means less area for blood flow to do what it needs to do to exchange the gases. So you get pulmonary hypertension, increased blood pressure in the pulmonary area. That's going to be caused by the COPD, the alveolar collapse, called cor pulmonale.
So you get hypertension in your lungs because your
On
body.
the vasculature of your lungs.
Because it's trying to push to exchange, but
There's not the gas exchange area that there should be.
Sounds like a backup.
In the lungs. Due to COPD. or pull one out. That is the best I've ever explained it because you just asked that question. Thank you. Now I know how to explain that better because I thought through it with you just. We can compensate. Okay, sometimes cardiac output falls, the amount of blood being injected, the ejection fraction falls, and our heart tries to compensate by increasing rate. Okay, so it's going to speed up. It's going to be tachycardic when we get to these patients. We'll get a stronger force of contraction, but this doesn't last forever. It makes the heart work harder. It burns up more oxygen. We can have the kidneys do their thing with that renin-angiotensin-aldosterone system we talked about way back in AED, where we reuptake more fluid, we pee off less. You guys remember the renin-angiotensin-aldosterone system? Yeah. So we can have our kidneys reuptake more fluid to increase blood pressure. We can make our heart work harder. And it does affect for a while, but it's going to make the heart work harder, meaning it's going to burn more oxygen, and the heart's unable to handle this increased volume, and things aren't going well, and then failure just gets worse. Symptoms of heart failure: shortness of breath, trouble sleeping, feeling tired or weak, nauseous, loss of appetite, restlessness, JVD. JVD is a late sign, so don't be telling me JVD all the time. When we see JVD in basically anything, ventricular vein distension is getting really engorged. We're nearing death sign. So if you tell me that's your key signs and symptoms from something, I'll be like, well, that's crap, because we should have seen something else first, probably. You can tell me it, but I want to know what else is coming with it. Handful,
Like not how much.
I mean, probably 10 times in my, it's not super often. Because, once again, I'm trying to fix people before we get to that. Like, people say tension pneumo, oh, they have this or that. I'm like, we should have done something faster. We'll check that one. Take care of your patient. Whatever's going on, they might need BiPAP, right? If their lungs are wet, they need BiPAP. If they're edema at the hands and feet, we're gonna take them to the hospital and check them out, and they might need dialysis. Who knows? Just depends on what's going on. Don't make them work hard. Making people that are in heart failure work hard is a bad idea. Maybe they have an LVAD. What's an LVAD? Left ventricular assist. Did you know there's RVADs? Same thing on the right side of the heart, just less common, okay? Yes, those are there, okay? This is a blood pump that pumps continuously. If external, we won't be able to pulse, and we won't have able to get good blood pressure because it's constantly pumping instead of what the heart does where blood does. They generally have an external battery, pump. Or an internal pump, external drive battery, okay? Call the LVAD center for help. Take them to an LVAD center. Those Plaza KU. Okay, and then on the other side is MU1, or do you go to
St. Louis.
St. Louis? That's done.
I know.
That's why we get some.
They get it done in St. Louis, then move in our district.
Cool. Okay, you can listen for the hum of the pump. If the hum of the pump's working, that's not the issue. So once again, auscultating with the stethoscope, when you're not sure if you have a pulse, listen. If you hear the hum of a pump, that's not the issue. We don't need to do CPR. We need to treat other things. If you don't hear the hum of a pump, they still don't want us to do CPR, but at some point you have to because the patient's dead. Call the center, ask questions. They'll help you. There's a number on every one of them. So tamponade occurs when the buildup pericardial fluid compresses the heart in that pericardial sac. I showed you the video on that. You get symptoms: Beck's triad, cold, pale, mottled skin, tachycardia, weak or absent pulses, and pulsus paradoxus. What's Beck's triad? You guys remember? Tachycardia. You're close. Somebody help her out. Do what? You get muffled heart sounds? Yes, that's true. That's not necessarily Beck's triad. You do get JVD. I'm gonna have to Google this because I don't think it's over here. Let me double check. JVD. JVD, hypotension, and muffled heart sounds. You should get tachycardia too. Did you say tachycardia? You were right. I'm sorry. Okay. Cardiac shock. This is one of those more of a catch-all terms. What's going on? Could be a lot of other things. And then the patient is going into shock. I don't like this. Hold on. So that's just kind of a catch-all. They could be in heart failure. They could be
one of many different conditions. IV fluids as needed, probably they might need pressors, so we can go dopamine, norepinephrine, or epinephrine. Remember, epi is primarily a what? Inotrope or chronotrope? It's a chronotrope, it's rate. It's gonna speed up rate, so if you don't need a rate drug, should you go with epi? If you need a pressure drug, you should go with norepinephrine or dopamine, depending on your protocols. And if you're gonna go with norepinephrine and levofed, you've got to fill the container first. Okay, hypertensive emergencies, they can be too high. We don't take these seriously enough. A lot of times I think we run so much hypertension that we just don't get too bent out of shape about it, but it can cause a lot of problems. 180 over 120 or higher can cause end organ damage. Even technically 140 over 90 is hypertensive. Okay, we see that all the time, so we don't worry about it. Not that we're going to necessarily fix it in the field, but we need to take them to the hospital and give them to the hospital to check out. So we can start getting on the right meds. Significantly shortens lifespan, causes that left ventricular hypertrophy or cardiomyopathy hypertrophy. Yeah, they can have nausea, vomiting, ringing of the ears, nosebleeds, muscle cramps. All this stuff can happen. Check BP in both arms. Might feel bounding pulses. Ask patients about what medications they use, if they're using over-the-counter drugs. Provide supportive care, IV line, don't delay. Keep going. Some places will use labetalol in the field. That'll manage that blood pressure. Just be careful, because you don't know how much they're going to drop. You don't know how they're going to react to that. We don't have labetalol. I don't know how many of you guys do, so not very many. It keeps. You can get endocarditis. It's an infection of the inner lining of the heart, characterized by endocardial inflammation. Here's when bacteria in the bloodstream colonize a heart valve or other damaged heart tissue. You weren't in here. Jared ran some girl that was putting coke or shooting up in her central line and then got bacteria.
Gross. That's disgusting. Yeah, that's gross. Nasty. So yeah, you're gonna get EKG changes. It's gonna look a little bit like pericarditis. They'll have all these symptoms. Not anything to necessarily freak out about. They need antibiotics. So pre-hospital IV lines, fluids, cardiac monitor, treat the patient, not the monitor. They need antibiotics when they get there. There's pericarditis, across the board ST segment elevation. They'll have just chest discomfort. It may be worse when they take a deep breath, or if they sit forward, it might feel better. Okay, typically with STEMIs, things don't feel better no matter what you do. So that can help. Don't use that solely, take the whole picture in, but if they start feeling better, if they take a deep breath and move, it's probably not a STEMI. Just be careful with that. Supportive care, IV fluids, they need NSAIDs, possibly antibiotics. Myocarditis, inflammation of the myocardium, usually benign and self-limiting. They get flu-like symptoms, chest discomfort, decreased appetite, palpitations, dysrhythmias. We're just going to take them to the hospital. Rheumatic fever, this is caused by strep. We get aortic or mitral valve stenosis leading to heart complications. Once again, supportive care, IV fluids transport. Scarlet fever, it's caused by strep. Sore throat, fever, rash, strawberry tongue. Typically, patients that are 1 year or greater or younger are at greatest risk. And antibiotics, we're probably just going to take them to the hospital. If they need IV fluids, we can give it to them. But most of the time, we'll just take them to the hospital. Aortic aneurysm, dilation or outpouching of a blood vessel. If they get to a dissection, aortic dissection, that's where we really have issues. We tear in the vessel wall, separates into layers. Blood fills the layers, causing them to separate, and then they can pour it out. That's not good. Can begin anywhere along the aorta, but must begin in the ascending aorta within 2 inches of the aortic valve, or in the descending aorta at the ligament arteriosum. They're going to have severe tearing chest pain front to back. When you're on your test, you hear the word severe tearing chest pain, and the back hurts too. That's probably an aneurysm, an aortic aneurysm. Okay? Tearing is a key word there. Yeah. It's difficult to distinguish between a heart attack, feel like they're going to die. Don't move them much because they might die. You can get pressure differences greater than 20 millimeters between arms. That could be a good sign in the test question that we're going with a dissection. The descending is less severe. Distal pulses are hard to feel, but that rupture can occur and then they bleed out and die. That's not good. IV line fluids transport carefully in that position you found them in. You get occlusions, it could be a thrombus, an embolus, tumor, or direct trauma. So we get a blockage of blood flow. We're almost done, guys. I know this gets just like we're beating you over the head in these last few slides. Like 15 slides to go. Thrombus is a blockage that affects an extremity. Muscle contraction may stop blood flow. That's going to be painful. So when they have thrombus, there normally is pain in that extremity. You may not be able to feel a pulse in that extremity. If you can't feel a pulse, it's more time sensitive. Embolus is most common, begins in the heart and travels to the extremities, occurs in patients with significant underlying heart disease. Direct trauma, you can get extremity trauma, which can cause basically some sort of blockage to occur there. Dissecting aneurysm, vasospasm. Vasospasm is normally due to IV drug use, which we already talked about. You can get acute limb ischemia when an arterial occlusion suddenly reduces blood flow. This is similar to what? What does this sound like on the vascular side? This is the arterial side. What does this sound like on the vascular side?
DVT.
DVT. Okay. So vein versus artery. Okay. IV fluids for these people. That's really what we're doing. Getting oxygen as needed, treating pain as needed. This 5 P's of whatever. I hate this, but I've seen this on the platinum. Pain, pulselessness, pallor, paresthesia, and paralysis. We know what pain is. We know what pulselessness is. What is pallor? Yeah, killer becomes like a off color, pale, but almost like a bluish, right? Paresthesia. I remember this question for the rest of my life because it was one of my last questions on National Register when I took my medical exam. It's about rabies, and it's a pins and needles feeling. So paresthesia is that pins and needles feeling, like that numb, tingling, burning sensation. Yeah, and you wake it up and it hurts like that. Or when you're like coming back from frostbite, you put your freezing cold hand under hot water. That terrible feeling, you know what I'm talking about? That's paresthesia.
In the heart?
No, not necessarily in the, we're talking about acute limb right now, but
yeah.
you need to know these 5 P's.
Ooh, easy. Yeah.
No. You need to know these 5 P's just across the board. Pain, pulselessness, pallor, paresthesia, and paralysis. I want you to know what paresthesia means because they'll talk about that in different times, but it's that pins and needles feeling. Yeah, heart rate, blood pressure, all that good stuff. Sit the patient out with their feet lower than the chest line. You don't want to try to force that occlusion to the heart because then they could die, right? That would be bad. 5 P's. I don't like 5 P's, but yeah, good. Thrombophlebitis is the development of blood clot in an inflamed or damaged vein. So a DVT. Guys, what I want you to think about when test questions DVTs, any kind of recent surgery, laying around a lot, driving, flying, long periods of time sitting, start thinking about DVTs, start thinking about what about the lungs? PEs. If there's a test question that says they just had surgery 2 weeks ago, they've been on bed rest, and now they can't breathe, PE. Okay? They have been on bed rest and they've had surgery and they haven't been taking their meds, and now they have severe pain in their legs swollen, DVTs. Okay? That's how they ask those questions. Don't rubber massage those things. You break that clot loose, thinking you're helping your patient with how bad it hurts. And now it goes to the lungs, the heart, or the brain. You just cause a stroke, a heart attack, or PE. You kill somebody maybe. So don't be rubbing on. We don't rub on patients. That's just, nope. Just a hard pass, hard stop. IV fluids, transport. There you go. That's 338 slides. Cardiology. We'll stop there for today. You guys have your packets. It's 3:30. I don't care. You do have to do those by next week. No matter if we have a snow day tomorrow or not. Doesn't really affect you. You have your packets. We're going to email out the packets to the other crew. There are 2 of them. They're not super thick. There's probably 60 some odd rhythms. I don't know. I didn't do math. Do the work. Next week's packet is 8. We're going to give you 2 weeks to work on next week's packet, but we don't want to fall behind, which means you have to get this week's packet done by next week. The next week's packet's really going to suck, so just know that going into it. Okay? I don't care if you hang out for a bit. I think you, maybe you should utilize that time, but you know, you do you. Yeah, did we not already hand those out? Oh, you weren't here.
So
Right.
we do this one, and finish the other one.
We should have already finished the other one.
Well, they weren't even told yet.
There's no 12 leads yet. The one we did last week. Oh, you're talking about that first week one. That first week one, let's not even worry about that. Yeah, we did. Let's just focus on these two. Okay. Let's not try to give yourself more work. Let's just focus on these two for now.
More heart rate of like 155 when we got. It took like 5 or 6 blood pressure was like 10 over 130 something. And he just repeats. Like, no, it's a good, you know, healthy meal, worked out everything. Sleeping then. And Mike said he was just crashing around violently.
Yeah.
And everything like that.
Bad reaction to that, huh?
And then he went to the bathroom, and that's when we came in, and he goes, "Don't scare the crap out of me because I was naked."
Oh, okay. I'm gonna stop this video real quick. Like